So, good morning to you all and thank you. I will start by presenting Professor Catarina Rezende, the President of ECHoS, and she will be opening the session for you and for us.
So, good morning, everyone. I'd like to welcome you all in this launch of the event of the European project ECHoS. On behalf of the Agency for Clinical Research and Biomedical Innovation, ICIP, I'd like to thank you for your participation in this kickoff meeting. Your presence today, either in person or through our online channels, is not only a sign of support and friendship, but also a sign of recognition of the importance of fighting cancer in today's society, as much in our own countries as in Europe as a whole. We have representatives from governmental organizations, both at national and European level, health professionals, researchers, patients, patient advocates, and professionals from the pharmaceutical industry. In addition, representatives from innovation, funding, and regulatory agencies and citizens on their own behalf have decided to join us today. This is a clear indication of one of the greatest objectives of the European missions, which is to involve in research multiple stakeholders, from individual citizens to transnational organizations, aiming to develop networks and synergies focused on the creation of cancer mission hubs with the goal of increasing the quality of life of those living with cancer. I applaud this vision and all the prospects it opens up to us all, that is, to the society. As many of you know, cancer is the second main cause of mortality in most European countries. Many national and international organizations are coordinating efforts in different areas to fight cancer. So this disease is often a driver of creativity, change, and innovation. I believe that with the creation of cancer mission hubs, we are witnessing one of these moments of change. Cancer mission hubs are national structures to echo the voice of citizens and other stakeholders in health research and beyond to policymakers. Cancer mission hubs are crucial to passing on guidelines, opportunities, and priorities from policymakers to national, regional, and local organizations, and to identifying needs and sharing competencies and knowledge among countries. I believe that what we are doing with a focus on cancer may well find its way to other fundamental aspects of human health and beyond. The European Commission has challenged itself and consequently the community to rethink health, to dare to achieve more, and to take risks in the new conceptual approach to research, that is to say, mission-driven research. So, accordingly, in the next couple of hours, we will learn about national and European strategies for and commitment to cancer research and policy actions with the participation of Paula Macedo on behalf of the Portuguese Minister of Science, Technology and Higher Education, who I would like to thank for joining us with a written message message from the Minister. This will be followed by a contribution from the Secretary of State for the Promotion of Health, Margarida Tavares. Thank you so much, Margarida Tavares, for being present at this kickoff meeting. So, due to last-minute scheduling conflicts, the European Commissioner, Maria Gabriel, will not be able to join us. However, she insisted on sending a written message that I will have the opportunity to transmit to you soon. So, before moving on the session, I'd like to acknowledge and thank all speakers who accepted to be part of this key event and share their knowledge and new ideas with us. Representatives of the European Commission for the support provided in the last months, and Informed for hosting this event. And all of you who aim to build a brighter and more productive future with everyone's collective effort. So I hope you really enjoy the meeting, and thank you very much for your attention. So I can really start with sharing with you the message of the European Commissioners, Maria Gabriel. So can you please share with us on the screen the message? So, dear participants, our Horizon Europe mission on cancer puts forward a new way to address challenges in beating cancer by creating a portfolio of research and innovation coordinated actions combined with new forms of governance and collaboration. With EU initiatives on cancer, we aim to improve the lives of more than 3 million people by 2030 through prevention, cure, and improving quality of life for patients and their families. I welcome the creation of national cancer mission hubs, the new important initiative of the Cancer Mission. The future mission hubs will enhance member states' capacities to integrate Europe cancer research and policy actions at national, regional, and local levels. By supporting cross-policy dialogues with stakeholders, these hubs will create a seamless link between R&I and policy developments. This is great news for European citizens, who will be the key focus of the Mission Hub's activities. The creation of Mission Hubs will be supported by the ECHoS project, led by the Portuguese Agency for Clinical Research and Biomedical Innovation, which will gather 58 governmental, healthcare, academic, and non-profit organizations from 25 member states and 3 associated countries. This is an excellent example how relevant stakeholders can work together in promoting collaborative initiatives. Only together we can beat cancer. Maria Gabriel, Commissioner, Innovation, Research, Culture, Education and Youth. So thank you very much, Maria Gabriel, for the message. And we are now moving to the next speaker. And it is my great pleasure to invite Paula Macedo for coming. The stage is yours, Paula.
So, good morning, all. I'd like to mention or acknowledge our Secretary of State of Health for the promotion of health. It's something that I really appreciate, Dra. Margarida Tavares. I'd like to make a special mention to all the representatives of the European Commission that are presented here, because this gives a strong message about how relevant this theme, how relevant cancer is in our lives. And last but not least, to ICIP, because it's driving us and leading us into this field within the clinical research and many other fields. So I'm here in the representation of my Minister of Science and Technology and Higher Education, and I'd like to thank the invitation to participate in this opening session. Although the Minister cannot be present due to agenda reasons, the government area of science had to be represented in this important event, which marks the launch of ECHoS. And what an important moment this is. We are giving one more step to the implementation of the mission on cancer under the Horizon Europe scope. ECHoS will enable the development of several national cancer missions hubs, as was already mentioned, which will prove to be decisive for the prevention. And prevention is really important. Early detection and treatment, and more important even, the quality of life and survival. Cancer is not and cannot be a death sentence. Science, over the last years, has been working on providing knowledge and treatment for the patients, and is allowing to increase the survival rate. Nevertheless, cancer is still one of the leading causes of death worldwide. According to data from WHO, another data, this one from the European Commission, shows that without strong action, the number of cancer cases in Europe will increase by 25% by 2035. Every year, cancer kills 1.2 million people in the 27 member states. We all want to save lives. Working with Europe's Beating Cancer Plan, we all aim to improve the lives of more than 3 million people by 2030 through prevention, cure, and solutions to live longer and better. To achieve this goal, we need to understand the different types of cancer and subtypes, to know the risk factors and their impact, and more important again, to prevent what can be prevented, to optimize diagnosis and treatments, to guarantee the life quality of patients and survivals, and ensure an equitable access to cancer knowledge and therapeutics. I believe that the mission on cancer will be able to achieve this great task we have ahead. In the framework of Horizon Europe, during the first 2 years, Portugal has already raised around 35.5 million euros to 48 projects that were approved, with a total of 108 national participation, representing a financial rate of return of 3.3%. Within the scope of mission on cancer, we are developing 10 projects, representing a financial rate of return on average of almost 2.5%. One of the most projects is ECHoS, whose main objective is to create the conditions for the establishment of the national cancer mission hubs. The major added value of this hub will be the possibility to transfer the knowledge and innovation produced within the scientific community to to the development and treatment of therapeutics that allow the cure and to minimize the effects of cancer. Such transfer must be based on research and development activities with national, European, and international impact, based on strong collaboration across sectors and borders. This cooperation foresees bundling of cancer knowledge, sharing of expertise, exchange of data, and financial sharing. And all these variables will have a direct impact not only on health systems, but more special on patients. Studies have already shown us that cancer never hits the patients the same way and demands the intervention on several medical specialties. And that is why those hubs could be an opportunity to create integrated and customized responses. We must help a cancer patient with a treatment that takes into account their specific biology, genetics, behavior, psychology, environment characteristics. Addressing such specific features demands specialized medicine, proximity, and preventive precision medicine, which will be possible thanks to the synergies established and promoted by ECHoS to enable citizen-centered and translational strategies in order to prevent and treat cancer. The National Cancer Mission hubs will furthermore contribute to increase health literacy through cancer policy dialogues with the citizens, policymakers, patients, and their relatives, formal and informal caregivers, and representatives of for-profit and non-profit organizations. The more knowledge a person and a community have about a disease, the more aware they will be and better able they will be to prevent and monitor the disease. One last word, but not less important, to the Portuguese Agency for Clinical Research and Biomedical Innovation, ICIB, in coordination with the National Directorate General for Health, will lead the Portuguese Cancer Hub, promoting and supporting the implementation in Portugal of European initiatives against cancer and defining strategies for action and funding aligned with the National Cancer Strategy 2021-2030. Our national hub will have 3 important missions: encourage the adoption of new solutions, technologies, and scientific evidence in health system and national policies. A second one is to define strategy of funding actions for national priorities according to the Mission Cancer, Europe's Beating Cancer Plan, and the national strategy for the fight against cancer. And finally, to participate in European actions directed at national authorities. And to do so, ICIB can count with the support of the Portuguese government, namely the Minister of Science and Technology of Higher Education, because we believe that ECHoS will be a new pathway in the fight against cancer and to the strategic position of the EU as a leader in the global fight against cancer. Thank you.
So, thank you very much, Paula Macedo, for your enthusiastic words. And really, we feel that we can face the future with hope. And this is important. So, it is my pleasure to introduce Professor Margarida Tavares. And please, Margarida Tavares, can you take the stage?
Thank you very much, Professora Catarina. Deputy Director General for Research and Innovation, Mrs. Joanna Drake. Team Leader of the Directorate General for Health and Food Safety, Mr. Matthias Schupp. Vice Chair of the Horizon Europe Cancer Mission Board, Professor Christine Comien. Professor Paula Macedo, on behalf of the Science, Technology and Higher Education Ministry. Professor Catarina Rezende, President of IECIV and Chair of this meeting and this initiative. Ladies and gentlemen, it's a pleasure to be here with you today. And cancer is one of the major public health challenges of our times. The increase of life expectancy, but also the pursuit of unhealthy lifestyles and environments led us to face the consequences of chronic conditions. Among other diseases, cancer became a major public health concern and one of the leading causes of deaths worldwide. It is estimated that approximately 1 in 3 individuals will develop cancer during their lifetime, and cancer accounts for more than 9 million deaths annually worldwide. From a public health perspective, cancer prevention and control efforts should focus on reducing the incidence and mortality of cancer through a variety of strategies. These include promotion, healthy behaviors such as physical activity, healthy diet, avoiding tobacco and alcohol use, as well as increasing access to cancer screening and early detection programs. We should be very aware that poverty and social exclusion increase the risk of worse outcomes. This is true for all diseases, but also for cancer, as the lack of literacy, support, or access could lead to fail in prevention, diagnosis, and treatment. Studies have shown that death rates from cancer in countries with persistent poverty are higher. Therefore, we need a comprehensive approach that guarantees universal access to treatment from prevention to continuity of care, putting people in the center of the healthcare delivery system. Cancer screening programs are an essential component of cancer prevention and control efforts, and we are deeply committed to increase coverage. Screening tests can detect cancer early when it is most treatable and can help to reduce the incidence and mortality of certain types of cancer. All over the world, countries face some steps back on maintaining cancer screening programs running during the pandemic of COVID-19. Portugal was no exception, but thanks to the enormous efforts of healthcare professionals, all screening programs are now in place. Another important aspect of cancer control is ensuring access to quality cancer treatment and care. This includes providing timely and appropriate treatments, ensuring access to pain management and palliative care, and addressing the psychological and supportive care needs of cancer patients and their families. In addition to individual-level interventions, public health approaches to cancer prevention and control also addresses broader social determinants of health, such as poverty, inequality, and environmental factors that can increase cancer risk. Addressing these social determinants of health can help to reduce disparities in cancer incidence and mortality rates and promote health equity. These were also the main concerns when the European Commission launched the European Beating Cancer Plan in February 2021. The European Cancer Beating Plan is a significant and comprehensive initiative that has the potential to make a real impact on cancer prevention, treatment and care in Europe. aiming to reduce the cancer burden in Europe and improving cancer care and treatment for patients. The plan is a comprehensive and ambitious strategy that sets out a range of actions to tackle cancer, from prevention to early detection, treatment, and survivorship. One of the key objectives of this plan is to reduce the cancer burden in Europe by 15% until 2030. To achieve this goal, the plan sets out specific targets for reducing the incidence of certain types of cancer and improving survival rates for cancer patients. The plan also includes measures to improve cancer care and treatments for patients, such as increasing access to innovative cancer therapies, improving the quality of cancer care across Europe, and addressing inequalities in care and outcomes. In addition to these actions, the European Beating Cancer Plan also aims to support cancer research and innovation by promoting collaboration and data sharing, increasing funding from cancer research, and supporting the development of new cancer treatments and technologies. Research is of paramount importance if we want to be successful in improving cancer outcomes. In that sense, establishing cancer mission hubs can be a valuable approach to promoting cancer research, prevention, and treatment. As a collaborative research center, Cancer Mission Hubs brings together experts from different fields to focus on specific aspects of cancer. As Professor Catarina Rezende explained us, Cancer Mission Hubs can facilitate interdisciplinary collaborations and provide a platform for training the next generation of cancer researchers and clinicians. By promoting collaboration and knowledge sharing, these hubs can help to build a community of researchers and practitioners who are committed to advancing cancer research and improving patient outcomes. This requires significant resources and investments, but the potential benefits are substantial. By bringing together experts from different fields and promoting collaboration and innovation, Cancer Mission Hubs have the potential to accelerate progress in the fight against cancer. We cannot spare efforts if we want to achieve such ambitious targets. I would like to conclude by mentioning the Portuguese strategy against cancer 2030. This strategy, aligned with the European Beating Cancer Plan, sets the targets and goals for Portugal: reduce cancer incidence, improve survival and patients' quality of life, promote the equity and support survivors and their carriers. The strategy is the result of a lot of work from the Portuguese Cancer Program during the difficult times of the pandemic. I want to acknowledge the contribution of all these professionals who helped to build this important strategy. I also want to thank all those involved in cancer research, treatment, and care, and I'm certain that this journey will be a successful one. And as Maria Gabriel said in her message, only together we can beat cancer. Thank you very much.
So, thank you very much to our speakers. It's really very important to have the support of the Minister of Science, Technology and Higher Education. So thank you, Paula Macedo, for joining us today. And also, of course, our Minister of Health. And thank you so much, Margarida Tavares, for your words, kind words and enthusiastic words. So we believe that we are in the right way clearly aligned with the objectives of the European Commission, and really we are proud to have you all with us today. So thank you very much once again, and Annabella, the stage is yours.
Okay. Now a good morning to you all following us in the room and also online. Thank you very much for being present. This was a very inspiring opening session, and I would like to thank Professor Catarina Rezende, also Professor Paula Macedo, Dr. Margarida Tavares, and also the Commissioner for the nice message. And with no further delay, I would like to introduce the next session dedicated to the European Strategy on Cancer. As the first speaker of the session, I welcome Dr. Joanna Drake to the stage, the Deputy Director General in charge of Implementation, Impact and Sustainable Investments Strategy from the Directorate General Research and Innovation. Please go ahead, the floor is yours, and thank you very much.
Okay, it's fine, yeah. Good morning, everyone, and thank you very much, Annabella. Ladies and gentlemen, pleasure for me to be here. Very exciting moment in the rollout of the ECHoS project as part of the cancer mission. And I come here as Deputy Director General of DG Research and Innovation, under which, of course, the whole Horizon program is managed. And of course, part of those are the mission. But I have a special hat on today without wearing a real hat. But I'm also manager of the Cancer Mission, and I'm very proud to be part of this very exciting journey that is already, as you know, very well developed. It's a crowded space, as somebody put it recently to us, because there's so much happening, thankfully. But still, the burden is quite heavy on all of us. And therefore, there is a lot of sense in what the previous speaker said in the together part of the project, of doing this and reaching this together. So on behalf of Commissioner Gabriel, who unfortunately, as you heard before, cannot be with us today, I would like to congratulate the project leader for having brought so many partner organizations on board for this important initiative. This is really great news for EU citizens. Because it is a visible part, and it is a part of the project that can be really close to home, and where they could actually be part of the architecture also of reaching these objectives. And we hope that this will remain the key focus of the mission activities and also its achievements, the mission hubs. Today we are launching the ECHoS project, and I want to talk about as well, in doing so, on the mission on cancer, and how it is, in fact, a very integral part of the EU strategy on cancer. As we said earlier, a lot of progress has been achieved, I think, in the world, in Europe. So much happening in terms of research, in terms of innovation, in terms of diagnostics, in terms of really granular research that then leads to better treatment over the past years, most notably in the last 30 years. But the burden remains heavy, and it continues to grow in Europe as well. There are various reasons for this, which, of course, if we had to go into, and I'm sure some of the speakers later, much more competent than myself on cancer, will tell us about and will tell us where this is going. So what is the mission on cancer actually adding to this space? What is it adding? What is the added value? And I think the added value is in the way, in the methodology, in putting together two things. One is the acceleration of the production of scientific evidence, and secondly, also being much better in translating this evidence into concrete solutions for patients, for citizens, while at the same time, because Europe is based on equity, is based on solidarity, is based on equality of treatment, we have to also ensure that there is efficient access to cancer control as well and treatment, wherever you are living in the European Union. So putting these elements together, I think, is adding value. And we believe that the more we have this approach, and we believe that this is a good approach, the more we shall achieve. Again, not because not much has been achieved, a lot has been achieved over the years, but it's still this huge monster really threatening to grow and threatening to take over the lives of so many loved ones. So the whole mission approach, as you know, cancer is not the only mission. There are 5 missions under Horizon Europe. The others much more related to the other big challenge that we're all facing, and that's climate change and how it affects our behavior, our living in a city, our soil, our ways, our oceans, what we eat, what we consume, our skills. But cancer is one of them, and the whole umbrella of the mission approach is that, under Horizon Europe, is that we wanted to bring a new approach to solving things, to bringing to the table concrete solutions that people know are addressed with them in mind, with them having a better life in mind, despite being a cancer patient in this case, despite having climate change out there threatening us every day in the way we live. So I think it's all about the fundamental shift in the way we work, in the way that research and innovation funding is actually allocated while we are actually supporting policy making. So it's a symbiotic relationship as well. So it's the way of working, but also how we allocate the funds in order to ensure that policy making is influenced, and the other way around, policy making influencing the way that research and innovation money is spent. So the Cancer Mission aims to break down these barriers and bringing innovative approaches from research and innovation together with public health, data sharing, and digital policies, while at the same time, and this is a really important element, and for this I want to thank also the Portuguese government for being so visibly committed to this approach and way of working and wanting to stand out as a real believer and a real actualizer of this, is the commitment of the member states. We cannot do anything without the commitment of the member states. As you know, public health is a very national arena. We, of course, can be there to recommend. We can be there to bring together the great big brains that we have, the great big facilities that we have, also the big money together. But in the end, it is the member states who decide what's the best for their population, and in this case, to improve cancer control. We are less than 2 years from the launch of the missions, less than 2 years. So can we really make a real assessment of what the impact has been? Well, just for you to know, there is actually a midterm assessment happening as we speak, and the Commission will be issuing what we call a communication to the Council, to the ministers, in this case, the Ministers of Health, the Ministers of Research and Innovation, to assess how the missions have been doing. But can we really say that we have seen the impact of the missions? I don't think so. But are we going in the right direction? I think it's a fair question to ask after 18 months plus of the missions being in operation. And I think the assessment, even if maybe I'm preempting a little bit what will be said, and I swear to you I don't know what will be in the communication, but I'm hoping that these positive elements will come out, and there is definitely a move in the right direction. We can actually trace it. Because at the end of the day, we have to integrate what is the best out of research and innovation into health, and vice versa. And this is why both the Cancer Mission and the Europe Beating Cancer Plan were co-created, co-developed from the start. In other words, what does it mean in practice? That there was an alignment from the start, from conception. there were complementary objectives. And in order to feed them and to make those objectives attainable, there were complementary flagships also undertaken. They were agreed to by our Department of Health in the Commission and our Department of Research and Innovation, where I come from. But there was also a very important point which was also ensured, and this is not easy usually in operations, and that is the joint governance. Joint governance was established. In other words, as you know, when it comes to the missions, the working parties for both research and health work together. This is quite a first, I have to say, in our institutional setup, but it has not remained a first. It is now a pattern that is being followed also by some member states by setting up what we call the mirror groups. In other words, what exists at EU level is being replicated at the national level, an integrated approach to health and research policies. Examples of where this is done are Spain and Sweden, who are represented also here today. But let me just give an example of what integrating research and health policies means. I have my colleague here, Matthias, who will be presenting the activities of the Europe Beating Cancer Plan very shortly, and I will leave the details up to him. But I will just give one example just to prove to you that this is not just a fantasy of some imagination. And this is, the example is the revision of a council recommendation on cancer screening. As you know, there are national cancer screening programs, and again, this is a decision that is taken by the national governments, but there is a recommendation at EU level which at the end of the day reflects the years of research, years of observation, years of pattern observation in several communities on whether it makes sense to have national screening programs. And this recommendation, which has been extended last December after 18 years of not being amended, extending the screening to prostate, to lung, and to gastric cancer beyond the breast, the colorectal, and the cervical cancer, which was the recommendation 18 years ago. And I think this only happened because of this integration exercise that I mentioned earlier. So, given this context, the establishment of the National Cancer Mission Hub, as we are doing today, across the EU, will only increase the impact of the structural changes that we are having, and we make them visible and tangible. And I hope tangible, meaning visibly active, and one that involves not only the professionals, the researchers, those who are working in this area, but also the citizens who themselves have their own experience, advice, and also recommendations to make. So, for example, investments in R&I, in research and innovation, start to be more prominent in national plans for cancer as well. Another example that this is, the momentum is really bringing about a bit of moving and shaking here and there. And one of the examples is under the Recovery and Resilience Facility. The Czech Republic plans to strengthen the oncological prevention and care through the acquisition of technologies for comprehensive cancer centers. So in other words, money that was allocated to Czechia, to the Czech Republic, was actually, part of it was prioritized for this acquisition of oncological technologies. I think this is very encouraging, and I do hope that this will be emulated by other member states' governments as well in the plans, in the monies that are dispersed to them under whatever program or whatever scheme under the European Union budgetary architecture. The Cancer Mission encourages, as well as I've been mentioning, the broad engagement and active participation of stakeholders and citizens. Their involvement is critical for the development of the mission itself. Why? Because the mission needs to be embraced by all stakeholders to generate an even greater bottom-up movement. It brings us, therefore, today to the launch of this National Cancer Mission Hub. The National Cancer Mission Hub are an especially important aspect of the Cancer Mission, as they will bring the Cancer Mission to the national level and, most importantly, granularly to the citizen. This is why I'm convinced that the Cancer Mission Hubs will greatly help the Member States in at least 3 ways. First, it encourages them to align the national and regional cancer research and innovation programs by bringing the stakeholders, the cancer stakeholders, and the citizens together. Secondly, by facilitating the cooperation between research and innovation and healthcare ministries to enhance meaningful outcomes for citizens at risk of cancer and living with and beyond cancer. Yes, these are also increasing, thankfully, I would say, but we also have to work a lot there. This is why one of the objectives of the Cancer Mission is also increasing the quality of life of young cancer survivors and the family. Why? Because we still have a stigma attached to cancer survivors. So not only have they gone through the ordeal, they have survived it, but then they have to live with a stigma. I don't think this is acceptable, and I think we need to leverage against that at European level. Thirdly, also by providing a network for long-term collaboration on the Cancer Mission, the Europe Beating Cancer Plan, and the national initiatives to support Member States achieving national cancer plan milestones. The mission hubs will therefore play a vital role in implementing the mission's flagship initiatives that are the Understanding uncan.eu platform and the European Cancer Patient Digital Centre. A third flagship is the development of the comprehensive cancer infrastructures in Member States. Here, the project of comprehensive cancer infrastructure in Europe that will be launched, in fact, later this month, will support this development. And I welcome very much the participation of the project coordinator in today's event too. These 3 flagships taken together have the potential to hugely speed up progress in our understanding and management of cancer. Between 2021 and 2023, the Cancer Mission has made 365 million euros available to support research and innovation projects and the development of flagships mentioned earlier, under each of the mission objectives: the understanding part, the prevention part, diagnosis part, and the treatment and the quality of life part, all 5 objectives. In fact, I recognize an increasing interest from researchers and Member States in the mission calls. The 2023 call, which recently closed, had 107 applications submitted to the various topics, with some being extremely popular. Citizen engagement to shape future policy actions and research priorities is an important part of the Cancer Mission. It should also become an important activity of the future national cancer mission hubs. Under the quality of life objective, the Cancer Mission has launched a new dialogue with young cancer survivors. For those of you who were there, it was quite a very deep experience for all of us, having the cancer survivors there, young, very, very much looking, to contributing to life, to society, having their own life, and at the same time, being very, very personal, at the very personal level of the experience and of what they would like to see for those who would have the misfortune of having the same experience as they did of being a cancer patient and having the fortune as well of being a survivor. This then resulted in other workshops and a conference organized in February of this year to discuss the specific needs of young cancer survivors and their caregivers. I think this is an area where we could really achieve a lot in a short time if we work smartly together. This dialogue gives young survivors a space to share their experiences, express their specific needs, and co-create initiatives with us to help address these needs. Many interesting ideas were put forward at the workshops and conferences, and these will help us to shape the future research and innovation and policy actions on childhood cancer and survivorship. There will be a follow-up workshop on the 26th of May with the same group of survivors to give feedback on future actions related to late side effects. So I want to congratulate this consortium gathered here today. Your work is important. You can now see the context in which you're operating and also the responsibility of it, I have to say. And we expect you to make a difference. This is why we're here. I wish you all well in bringing your plans to fruition by securing buy-in and engagement of different stakeholders and communities and keeping up the momentum and the impact. And I want to encourage every one of the 58 partners involved in this project to liaise with your local stakeholders, to involve citizens in your work, and to help accelerate cancer research in your country. Finally, I thank you for your attention and wish you good luck with the rest of the event today and also your further work tomorrow. Thank you.
Thank you very much. Thank you very much, Dr. Dreit. Indeed, we have a big responsibility in our hands. So I would like to present the following speaker that is joining us online, Mr. Dr. Matthias Schuppe, that will join, is appointed as a team member responsible for the preparation of DG Santé's work on the European Beating Cancer Plan at the Directorate General for Health and Food Safety of the European Commission. Thank you very much, Dr. Schuppe, for being with us. Please, the floor is yours.
Thank you very much, and good morning. Let me first congratulate you for these efforts of 58 partners to work together in these cancer mission hubs. We think this is an excellent approach, an important initiative to bring both the cancer mission and the cancer plan closer to the national level and closer to the citizen. My colleague Joanna has already expressed or explained a lot of the elements through which the cancer mission and the Europe's Beating Cancer Plan are closely aligned. And perhaps I can give a few more examples, last but not least, because I see on the program of today's meeting quite a number of these joint projects being presented. And I also note that the coordinators and participants of some of these projects are also partners in the ECHoS project. Perhaps let me very briefly outline the approach that's taken with the Europe's Beating Cancer Plan, a plan that has now been adopted for a bit more than 2 years. It was adopted in February 2021. And like the mission, it takes a very comprehensive health and all policies approach in addressing cancer, starting from prevention through early detection, early diagnosis and treatment, and then also addressing the quality of life of cancer patients and survivors. The cancer plan itself has 10 flagship initiatives and 32 other actions which address this disease continuum, and also includes cross-cutting themes, addressing research and innovation, digital and personalized medicine, a focus on inequalities, and also on pediatric cancer. At this stage, funded through the EU for Health program, we have up and running 28 projects that cover this entire disease continuum. And perhaps I can give you a few examples of that. The first one in the area of new technologies is a flagship of the European Cancer Imaging Initiative, which was launched in December last year. and which will be presented to you also today. That's the ECHIME project. Secondly, in the area of prevention, the cancer plan focuses in a flagship on the elimination of cancers caused by human papilloma virus. And we have already launched a number of actions, for instance, the joint action on HPV vaccination purge. And the Commission will present towards the end of this year also a proposal for a Council recommendation on vaccine preventable diseases to also create the political momentum jointly with member states to address and achieve this goal. As Joanna already mentioned, a second flagship is a new EU cancer screening scheme, which has at its heart the new Council recommendation on cancer screening adopted in December. And now DG RTD through the Cancer Mission and DG Santé through the EU4Health program, also in support or supported by the Cancer Imaging Initiative, are working together to put this recommendation into practice and support member states in their implementation. For instance, through a number of projects which were already launched, focusing on prostate, lung, and gastric cancers, though these 3 new cancer sites that are now part of the expansion of the Council recommendation. And we are just now in the process of launching direct grants to member states to support member states with the full implementation of the screening recommendation, focusing both at the old sites, breast, lung, and colorectal, but also at the 3 new sites. Moving then forward on the area of cancer care and treatment, it was already mentioned, and this was a joint objective or joint recommendation, both by the mission board and then taken up by the cancer plan to support the establishment of comprehensive cancer centers and infrastructures in EU member states and facilitate their EU networking. Under the health program, we have launched the joint action CRANE, which is a preparatory joint action and would develop a concept for an EU network of comprehensive cancer centers and also look into how comprehensive cancer networks can be integrated into this network. And also aligned with that is the CCI4EU project that will look at certain other elements of comprehensive cancer infrastructures, for instance, training and further supporting measures. Last but not least, and again, this is perhaps completing the alignment, we are also jointly addressing the issue of quality of life of cancer patients. And here have launched, for instance, actions that develop a cancer survivor smart card, address access to financial services for persons with a history of cancer, the so-called right to be forgotten, and have also established a network of youth cancer survivors, which is working jointly with the Cancer Mission and some of these projects in improving the quality of life of cancer survivors. So this in a nutshell is how closely aligned and how much ground we have already covered with the Cancer Mission and the Europe's Beating Cancer Plan. I think the mission hubs are a very important and necessary addition to this repertoire to ensure that we can learn from each other and that we fully engage with the national and local stakeholders to really put the achievements of the Cancer Plan and the Commission and the Cancer Mission already on the ground and ensure the full implementation at national level. We would like to encourage member states and all stakeholders to make fully use of these hubs and mobilize as far as possible resources to ensure that they are in excess and excuse me, a success. We will also keep our governance mechanisms, for instance, the cancer subgroup, which represents both ministries of health and ministries of research, fully abreast of these developments, that they can also further support and link to the mission hubs to ensure good progress. Thank you.
Thank you very much, Dr. Schuppe. And I will now pass to the next speaker. It's Dr. Sara Cerdas. Dr. Cerdas is a member of the European Parliament. She's Portuguese also. And it's part of the Special Committee of Beating Cancer, BECA. Unfortunately, she cannot be with us today, but she still sent us a video message that we will now see. Thank you.
Hello everyone, and thank you very much for having me here. Dear distinguished guests, it's my pleasure and honor to be here today to talk to you about the ECHoS project and its significance in shaping the future of cancer care and research in Europe. Cancer is one of the major health challenges within global level. It's not only a main priority for the World Health Organization, but it's also a priority for European Union. And we have been working tirelessly on the new European Beating Cancer Plan, which we have a Parliament's position when it comes to it as a special report from a special committee of which I was honored to be the vice chair of. It's the second cause of death in the EU, and the ECHoS project is a research initiative funded by the Europe's Union Horizon 2020 program. So this project aims to establish a network of cancer mission hubs in Europe that will work together to improve cancer care and research in the EU, and the hubs will be centers of excellence. And these centers of excellence would bring together not only clinicians and researchers, but also patients and industry partners in order to share better knowledge, resources, and expertise. The hubs will focus on specific cancer types and will work to develop new treatments, diagnostic tools, and care pathways for patients. This project is one of the many initiatives that are part of the Health in All Policies approach adopted by the EU. And this is something that guides me since I was first elected for this European Parliament in May 2019. I started my mandate in July 2019. The concept of health in all policies recognizes that health outcomes are influenced by a wide range of factors beyond just healthcare provision, and it considers the health impacts of the different policies across the different sectors that we have in health. Another key initiative that is closely related to the ECHoS project is the Europe's Beating Cancer strategy, which I previously talked briefly about. And this initiative aims to reduce the cancer burden in the EU and improve cancer patient outcomes and quality of life. The Europe's Beating Cancer strategy focuses on 4 key areas, which are prevention, early detection, diagnosis, treatment, and quality of care and quality of life. The European Health Database is also another initiative by the EU, and it's a file very close to my heart as I'm one of the negotiators, and it will also enable better data sharing of health across the EU, and it's very much aligned with the ECHoS project. Moreover, the European reference networks will improve further patient care by connecting healthcare providers across Europe and sharing knowledge and expertise, and once again, very aligned with the ECHoS project. So in conclusion, the ECHoS project is a critical initiative that will shape the future of cancer care and research in Europe, and it's very much aligned with a lot of the regulations and legislations that we have been dealing with during this mandate of 2019 to 2024 here at the European Parliament, at the EU institutions. So this is briefly my comment and testimony to the EU's commitment to creating better health and well-being for all across all policy sectors. This is something I'm firmly working on to make it a reality for the EU and beyond, for the 450 million citizens that live and work here and beyond. And I truly believe that only by working together we can improve the lives of these million of people, make them improve their well-being, and make a real difference in the fight against this devastating disease that affects 1 in every 3 people, that is cancer. So we must keep working together, and thank you very much for the honor to be here today and convey this message to you, and I wish you an outstanding event.
So thank you, Dr. Cerdas. And now, to close the session, I have the pleasure to invite to the stage Professor Christine Chomien, the Vice Chair of the Horizon Europe Cancer Mission Board, to come and provide us the view of the board for the European strategy on cancer. Thank you very much.
Thank you very much. Thank you, Annabella. Thank you, Hugo, to invite the mission board to be part of this launching. Launching a boat, I'm missing this champagne. Not because I'm French. It's the vision I see of the boat, which just came to me, thinking about the first words I would say to both of you and your group. Is that we're launching the boat, and you've got the work to do and to make it sail with all the trips you need to do. But the boat took a long time to build, and so I'm congratulating you already on the work that you've put through with all your stakeholders in making this ECHoS boat so that it can sail right through all the member states. So thank you for inviting the board, and after the very important words of Commissioner Gabriel and our mission manager, Joanna Drake, I will focus essentially on what you believe and hope the board members do. So board members, and the role of the mission board is to advise. And so theoretically, our role, whether it was from the first Cancer Mission Board, and one representative is here with Bettina, was essentially to advise by collecting as much as possible very important inputs from, as you can imagine, all the stakeholders who participate in cancer, whether they're European organizations, scientific organizations, also private pharma organizations, and also citizens and patients and parents of pediatric cancers who give us what they believe were their needs. You mustn't forget that the mission concept states that the mission has to provide solutions for the needs that the citizens face every day of their life to face the challenges, and cancer is one challenge. And so the first role was to advise and to recommend what we thought as board members, but also, as I said, after numerous consultancies, leaning also on our assembly members to provide recommendations on what we thought that the European citizens and the European Committee on Cancer thought was needed for breakthroughs to really answer the challenge of cancer. And so I'm very happy, as it's been stated already by Joanna Drake and by Matthias Schupp, that when we started as board members in September 2019, DG RTD, Research and Innovation, and also DG Santé were really sitting together with us to try and work together at the best means to be able to answer this challenge. And so it's not surprising that the 5 intervention areas that were identified, which was to understand, we cannot improve efficiently what we do not understand, prevent what is preventable, improve diagnostics and treatment, improve quality of life, of patients, carers, and survivors, and all this for all EU citizens in Europe. These 5 pillars are really the terminologies that you also see in the Europe's Beating Cancer Plan. These 5 intervention areas, as you remember, led and were supported by 13 recommendations. And so now we face, in the last, let's say, 18 months, really the launching of these recommendations through 2 opportunities which are important to be together. Otherwise, we would not be able to achieve our goal, is to have the Horizon Europe Research and Innovation together with DG Santé and Europe's Beating Cancer Plan. I don't work at DG RTD, but I assume it's not DG RTD's role to answer policy questions. And of course, it's not automatically DG Santé to answer research and innovation questions. The tools to answer are different. And that's why it's very important that we have the 2 opportunities working hand in hand to be able to answer the recommendations. I'm very excited, and I really always take the opportunity to thank DG RTD, to thank HDR, to thank DG Santé, because of our 13 recommendations. All the calls that are coming out very fast now are really related to the recommendations of the first mission board. And what's crucial also, it's something maybe you do not all have in mind, the house of our 5 intervention areas. But the board members really recommended to DG RTD, DG Santé, and HDR that when the calls came out, they had to be able to address all 5 interventions at the same time. Otherwise, the house would fall down. And I'm very happy also to see that each work program of the mission actions, they always address all the 5 interventions at the same time. So there's not much more for prevention than there is for quality of life, or for diagnostics and treatment, or for understand. Each time a work program comes out, it addresses each pillar and each floor of the house of the mission board. So for me, it's something which is very difficult to do. I've been doing research programming in France for cancer. It's not always easy to launch all these calls, and I really congratulate the work being done by the European Commission. What we are doing now as the board of the second life of the mission board is, of course, as you understand, the implementation of these recommendations. And I know that some of the board members are online, and we have one representative here on top of me, which is Nevenka Maher, who's here present today. For us, our job is difficult, but it's also going to be difficult for you, and that's why I think we need to work together, is to be able really to implement the recommendations. As I've said, I'm very happy that the big momentum that has been created in the last 18 months or 2 years through the Europe Beating Cancer Plan and through the Mission Cancer Actions has provided an enormous momentum, where I hope that at some level, whether, as Master Schupp was saying, through the SGPP subgroup, where ministries of research members and Ministry of Health members were together, listening regularly, nearly every month, to what is happening at the European Beating Cancer Plan, at the mission actions, and we're asking them exactly what is the feedback at the member state. So this is also very important, that at least the momentum has been created through just the example of ECHoS, with your 58 stakeholders and your 25 member states. All these people which are participating in all these consortia which have been created so far are very important to really, I think, make the mission cancer and the Beating Cancer Plan visible. However, and I'll finish by this, it's visible amongst us, and thankfully, most of the people in one consortium is sometime in another consortium, so at least it creates a coherence in all these consortia. But we're still in a world, and I'll take an example, we're still in a world where we all speak English. If you want to be able to answer a citizen's or a patient's needs, you cannot speak in English. You have to speak in the patient or the citizen's language. but even further than the patient and the citizen's language. If you want to convince, if you want to work with the stakeholders, whether they're at the ministry level, medicinal authorities, whether it's a pharma, whether it's a university, an insurer, it's very complicated to be able to get these stakeholders to work together if they have to think of talking in a language which is then not their own. So our work now is to be able to really try and push the mission concept at the national level in the national language. And therefore, that's why the call, which was absolutely needed, which is the one on the cancer national mission hubs, it's absolutely instrumental to be able to do this work. Of course, we are asking you to do a lot, but as board members, we've been and we still are, quote, ambassadors. Of course, we're only 15, so a bit less than the member states, but we are ambassadors for 1, 2, or 3 countries at the same time. And we are there also, like you, as ambassadors, to try and collect the needs at the national level so that we can advise the Beating Cancer Plan, we can advise the mission calls and the other mission board members, but we also can go back with you to the national level, regional and local level, to be able to explain and what is being done at the European Brussels, European Commission level. So I think I'll end this, but it's something that we are here. As I've said, the ministries are very well involved now. Don't forget the national contact points. That they're also regularly to be able to help. But we need to be able to work together so that at the national level, at the regional and local level, we can get all the stakeholders together, because that's the mission concept. As Joanna Drake said, the added value of the mission is to provide a way, a path. It's a new way to program research, and it's through this new way of program research that we can have an added value. And this new way is by bringing all the stakeholders together who want to answer the needs of a citizen and a patient. And we can only do this in the national language. Thank you very much, and congratulations, and we're there to help you.
Thank you very much to all the speakers in this panel. So the expectations are high. So now it's time for me to present myself, because I'm the next speaker. And so I'm Anabela Isidro from the Agency for Clinical Research and Biomedical Innovation, and the coordinator of the project, together with Hugo Soares, that is somewhere there. And I will now present the project, but still a little bit more of suspense. Before, I wanted to tell you some words about our agency. That is, so I have to go. So this agency it's quite recent. It's a public-private agency, and we have both representatives from the Ministry of Health and the Ministry of Science, Technology, and Higher Education, and also from the partner side, from the private side, representatives from the Pharma Association and the Health Cluster Portugal. So we have as the mission to promote, coordinate, and support activities in the areas of clinical research, transnational research, and biomedical innovation, contributing to the optimization of the Portugal clinical, scientific, and technological potential. And we have as a vision to be a national and European reference as an entity capable of creating the essential conditions to stimulate clinical research and biomedical innovation in Portugal. So we have basically 3 strategic pillars. The first one is dedicated to foster clinical research and biomedical innovation. And here, besides the biomedical innovation, we are very concentrated on the clinical studies, particularly the clinical trials, where we have a lot to do in Portugal, and we are way behind many countries in Europe. And this one of our focus. In the next pillar, we are more dedicated to the training and network, and here I'm not speaking only about the health professionals, but also the patient associations and patients themselves, so that they can also help us and contribute in every stage of the research, and also we want to create a network of clinical research and biomedical innovation stakeholders. And finally, we have the support to the internationalization, where I'm the responsible for. And here we also have, besides participation in many European programs, we have also the national contact points for the Health Program Committee that are today here in the room, together with me, and also for the Digital Europe program, the part of the health. So, but without further delay, I think you want to hear about ECHoS. And I have to say that I couldn't be prouder and happier to coordinate this project. It's been a pleasure since the beginning with all the people that we work with to do this proposal. So it's also it's a very challenging endeavor that is the fight against cancer, and we are happy to contribute. So, I now invite you to go through the ECHoS project. So our aim is to, as was already many times said, establish national cancer mission hubs in all member states and associated countries. What a huge objective and aim. We have lots of work to do. And how do we plan to do it? We will build on existing structures or by creating new ones in cases that there is no structures. And we will integrate the mission activities in national, regional, and local levels. To what? To raise awareness to mission on cancer. We will target all relevant stakeholders, from citizens, patients, national and regional and local stakeholders, but also researchers, innovators, organization of the health system. And the challenge is to go beyond the research and innovation and beyond the health systems. So how we will tackle that? So we will implement new participatory formats, engage all relevant stakeholders in policy dialogues, and get support from and synergies with many, with the programs, European programs, also taking advantage of the National Contact Points Network and National Focal Points networks, and all the initiatives that are in Europe that are many. Also, the European Beating Cancer Plan is very important. And for this, with this, we will raise awareness to the mission on cancer. So we are a quite large consortium, as it was already said. We have 28 countries on board, and we have now Denmark that already showed their interest to join. And these are 25 member states and 3 associated countries already, 58 organizations, the countries are here, the flags and the names, and many organizations from very different sectors. So we have some of ministries of health, ministries of science, national cancer institutes, very important institutes, and also a European Cancer Organization on board, so we are quite a diverse group, and I think this is also one of the strengths. Being diverse, for me, it's always, my personal view is that it's always positive. And from the Portuguese side, I cannot help myself to thank also to the Directorate General of Health and to the program, national program for oncological diseases that work very closely with us and with our National Cancer Hub. So how we will plan to do this? We divided us in 6 work packages. The traditional one, governance and implementation, of course, very important. And we will have a work package dedicated to the design, creation of the national mission, cancer mission hubs and the knowledge exchange. Another one to impact models and stakeholders in engagement. The 4th will be dedicated to synergies. It seems very easy, but it's not straightforward. Yesterday we had our first executive committee, and there were many discussions about this. We will hear more today. And the work package 5 that is more looking to the future, to the future network of cancer mission hubs, a design study, and also to the sustainability, and of course the transversal work package 6 that is dedicated to communication, dissemination, and citizens' engagement and participation. So with all of this, we hope to involve to involve in a co-creation, co-development, and co-assessment process all the stakeholders, from unusual actors, researchers, NGOs, citizens, the commercial sector, governments, etc., addressing health research needs and create informed citizen-centered policies towards the common goals of the mission on cancer. Also, we will build synergies with the many programs and in partnerships, having also always in mind, of course, also the European Beating Cancer Plan, and together with the activities of the mission, but also the Digital Europe program and many others, together with the panoply of initiatives that we already know they are there. And we want to research and to create the research and development initiatives that will contribute to responsible citizen-centered innovation, contributing to the central goal of the mission, that is improving the lives of 3 million people, which is also a very ambitious goal, but we are very happy to contribute to this important goal. So basically, we want to create an ECHoS now. In all the countries that are now present in this consortium, but also in other countries that we want to involve afterwards. And we will build on the different sectors, having all in mind and having this big goal in mind, that is to improve the lives of 3 million people. It would be even great to improve more than the 3 million people, but if we improve 3 million is already great. So basically, we will involve all stakeholders. We will activate, mobilize, ECHO. Then we want to prevail, and we want to create a culture on cancer to improve 3 million lives. So breaking through cancer, hopefully. So last but not least, I just present our team. So with me, I already told that Hugo Soares is co-coordinating this project. Yasmin Fonseca is a project manager. José Salvado is in charge of the communication. And Laura Gomes is in charge of the financial issues. I would also like to send a big thanks to Afonso Duarte and Isabel Carvalho de Oliveira, which are our national contact points, and that they were giving a lot of support during the project preparation and grant agreement preparation, and so it's very important to have them also with us. This is also an advantage of our institution. So thank you very much, and I think now it's time for lunch, but before that I invite Hugo to give you some housekeeping, and thank you. Come on.
Thank you, Annabella, and we are just a few minutes late for lunch, so I will not keep much of your time, just to say that lunch will be served just behind the gray wall where was the coffee welcome, so you're welcome to join. Those that have food restrictions, there will be an area with special requests, so you can have vegetarian and allergies, whatever. It's in that safe area, please go there. Also to say, please, there are no power sockets in the auditorium, probably you already saw it and noticed it. But if you need to charge cell phones or computers, welcome to go to next door to the secretariat. We can charge. We cannot charge all at the same time, but at least we have a kind of solution for you. And last but not least, also to ask your attention, as a satellite event, after the end of this event today, we will have a debate for the national TV Seeking Thesis. It will be aired later on this week and also on the social media. It will be about what we are doing here today and how it will be received by the national organization. So it will be in Portuguese. I invite all the Portuguese people to stay to learn more about this event. It's not in the program because it's satellite, but you are more than welcome to join us in this event as well. And we are returning after lunch at 1:30. Enjoy, and thank you all for being here today. Good afternoon. Thank you again to this afternoon session. I hope you enjoyed your lunch because this afternoon will be just exciting. We will start with Mark Lawler presenting the Groundshot Initiative, the Cancer Groundshot Initiative, which is a data-based initiative on cancer, so we know exactly where we stand, so we can plan exactly where we want to go. And with this study, we expect to shed light on the fundamental questions such as inequalities, funding opportunities, and healthcare and survivorship, so we know better how to plan and how to act. Professor Lawler is an international renowned scientist who has published more than 200 papers we commonly find his name associated to very high standard journals such as Nature, The Lancet, and the New England Journal of Medicine. Professor Lawler has a strong commitment to patient-centered research, care, and to addressing cancer inequalities, being in the origin of the European Cancer Patient Bill of Rights. The Bill of Rights has been adopted by at least 25 European countries and received the prestigious award, the European Health Award in 2018, an award to partnerships that yield real health impact in Europe. It is thus my pleasure to welcome Professor Mark to the stage and to listen more about the initiative on cancer.
Thanks, Hugo. Thank you, Hugo, and thank you for the invite. As I was sitting on the runway in Washington Dulles Airport yesterday afternoon, and the time kept ticking by and it was getting closer to missing my connecting flight from JFK to here, I started looking to see how am I going to get to Lisbon. And there are a lot of ways to get to Lisbon. You can go via Amsterdam, you can go via Barcelona, you can go via, and I can tell you I was nearly booking a number of those, but thankfully I just about made it in time, if somewhat hyperventilating at the gate in JFK. So thankfully I'm here this morning or this afternoon. What I'd like to do is really share with you work that we've done over the last 3 years that I think is very relevant to what you're doing today. And I would echo what was said earlier in relation to this is a superb initiative that you're driving, bringing 58 different organizations from different countries together across Europe is truly inspiring. And I'm really looking forward to seeing the fruits of your labor over the next 2 to 3 years. What we wanted to do really was to look at, what's the state of play in Europe at the moment in relation to cancer research and how it's being translated into cancer care. And in order to do that, we really had to say, well, let's be honest here. Okay, let's look and see what is happening and what can we do about it. And I'm going to sort of state the proposition that Europe is really facing a cancer crisis. And it's something that we really need to act on. And research is a critical component of that action that we need to take. If we look at the complications of COVID-19, particularly in relation to cancer care, cancer research, and cancer treatment, we see significant impact, and I'll touch on that a little bit later in the talk. But we also see influences from the Russian invasion of Ukraine, again, something that I'll touch on slightly later, and also the global economic downturn. So we're in a very challenging situation at the moment, but I really feel we can be proactive and drive forward. But the important thing is that we need to act now. And that was something that, when we brought together this Lancet Oncology Commission, which was approximately 55 different people from right across the cancer continuum, cancer patient advocates, researchers, clinicians, healthcare professionals, really bringing everybody into play, to really challenge what we were doing currently. And I make no bones about that. We wanted to say, is what we're doing at the moment actually the right way to go forward? Or are there ways in which we can actually change, look at ways in which we can do things slightly differently? And one of the things that we focused on was the need to have data. And the need to have data was really important. And this comes quoted from the Lancet Oncology, from the Groundshot that was launched in November at the European Cancer Organization Summit, and then published in Lancet Oncology in January of this year. I'm just going to focus on a few words from it. Too often opinion, even expert opinion, has trumped data in the genesis and implementation of cancer research policies. I make no apologies for that statement, because I think it's actually true. And one of the things we sort of said, and we've used it as a soundbite, and to give, it's sort of probably opposite at the moment, given that we've just come for lunch, because I would say that data eats opinion for lunch. And we really need to have a much more data-centered approach to seeing what is the evidence that's out there currently, and using that then to drive our research and innovation agenda. Obviously, the choice of the name echoes the US cancer moonshot, but we felt there were things that need to be addressed on the ground as well as shooting for the moon. And I've just come back from the NCI in Washington, and one of the things we're looking at is how the moonshot and the ground shot, but also the National Cancer Plan that Monica Bertoloni just announced and launched there 2 weeks ago. It's really relevant that we work together. And if there's one message I want to get out of this, is the need to work together, the need to follow the data, follow the science, and act on it. One of the things that has come out of the work that we've done, really not just over the last 3 years, but probably over the last 10 years, is trying to have a vision in terms of where we want to be going forward. Because a vision always drives you then to look at ways in which you can implement that vision. And our vision is to achieve 70% long-term survival by 2035 for the 20 million European citizens living with and beyond cancer. It is an ambitious aim, but we feel it is really important that we have an aim, such an ambition at that. And it obviously echoes both the European Beating Cancer Plan and also the US Cancer Moonshot. And the other thing that's come out of the work that we've done, and again I want to emphasize this, is that patients who are treated in research-active hospitals have better outcomes than those who are not. So categorically and unequivocally, research is not a luxury. It's an integral part of 21st century cancer care. So we need to get that message out there, because it's really critical. People sometimes think about research as an add-on, an extra, a luxury. It is not a luxury. It is an absolutely critical part of how we need to deliver 21st century cancer medicine. We started then to look at different studies within the overall ground shot to look to see, well, what is the state of play currently? And this is just looking at cancer research activity in Western Europe as opposed to Central and Eastern Europe. And unfortunately, what you see is that in Western Europe, it's essentially booming, and this is reflected in the originally EU15. And unfortunately, for countries in Central and Eastern Europe, it's tending to flatline. So we need to do something about that, because it should be the right of every European citizen, no matter where they live, to have access to the best quality research and innovation that's driving their care. And so we have indicated that we really need to look at capacity building, twinning, ways in which we can actually enhance research activity and quality in Central and Eastern Europe. The other thing is funding. I've received a lot of criticism for this slide, but I'm not going to back down on it because it's true. We've checked the data is correct in relation to this. If we look at the spend on cancer research, public spend on cancer research in Europe and in the US. In the US, the spend is $234 per head. In Europe, the spend is 26. So we're advocating at least a 50 or 100% increase in that spend over the next number of years, but we really need to do more than that. So it's really critical that we are honest with ourselves, look at what the data tells us, and then use that data to actually drive change. The other thing is looking at the research portfolio. We're doing great things in discovery science, we're doing great things in personalized medicine, but they're not the only things we should be doing. We should be looking at widening our research portfolio, looking at all disease phases. I've just come back from a think tank in the NCI where we're looking at pre-cancer and trying to define what pre-cancer is and coming out with a white paper in relation to pre-cancer. So it's obviously very important to look at that aspect. We also feel that looking at different cancer types, but proportionate to their incidence and their burden in Europe is really important. And also much greater emphasis on health policy, systems research, and implementation science. If we just look in relation to some of our decision making in relation to what diseases we focus on. I'm just going to focus on lung. So there we see lung, 21% of the disease burden in Europe, and yet we expend 4% of the research effort. There are other diseases, pancreatic, colorectal as well, that are showing similar. So we really need to look and see, are we addressing the right questions in the right diseases at the right time? And looking at this data, I would suggest that we probably need to do a little bit of a refocus. And this is just showing you that in sort of looking at cancer burden right across a whole range of diseases. And that data is all there. The other thing is this data is all available open source to you. It's also going to be available on the European Cancer Pulse that I'll talk about towards the end of the talk. So we want you to take this data, interrogate this data, use this data. There's a wealth of data there. We weren't able to do all the analysis that's required in relation to the type of data. So very much would want you to come and talk to us, make use of that data, use it to drive your own research initiatives as well. Okay, again, I'm probably going to get criticised for this, but I do work in Northern Ireland, which is a part of the United Kingdom, unfortunately. And so we did look to see, well, what is the impact in relation to looking at the EU27 or the EU28? And you can see there the impact is quite significant. So we need to look at ways in which the UK can continue to partner. I'm not making any criticism of the EU or the UK in this, but I'm just saying the reality is that cancer research in the UK is strong. So it being part of the European cancer research effort makes a lot of sense. Ways in which we do that, obviously we need to look at ways in which we can do that most effectively, and part of that pressure is on my own government in the UK to do that much better. But it's unescapable there. We're not going to get to that level of both activity and also quality if we just exclude the UK from cancer research in Europe. So cancer really should know no borders. This is data that I'm really disappointed in. So what we did was we looked at the gender equality or lack of equality in cancer research, and it's really quite disturbing if you look at it. So we looked both at first author paper and last author paper. So first author papers for activity from female cancer researchers, last author for leadership in relation to cancer research. Unfortunately, what you can see is there's a significant gap between, particularly if you look at some of the countries over towards the right, and also if you look, we did a similar study that I'm not presenting the data on to show that we saw the same thing in relation to cancer research grants as well, again reflecting leadership. So that 65-35 ratio needs to change. Some of our most prominent countries in relation to research have very poor, sometimes less than 25% female cancer research leaders. That is not good enough. I'm calling it out. I've called it out a number of times, and I will continue to call it out. And we need to learn as well from the Central and Eastern European countries and the Nordic countries who show much better evidence of female cancer research leadership. And the other thing is looking at what do we spend our money on, what do we focus on? And again, it goes back to what I said in relation to that portfolio needing to be wider and not just focused in one or two areas, but a much wider focus. And most importantly, we need to be able to implement. So that's sort of focus on prevention. How much do we spend on prevention in cancer research in Europe, percentage-wise, of the overall research budget? Can anybody tell me? 4%, that's what we spend. So we need to change that. And the other thing is, this is just some data from Theodora Kolarova from work they did. And the reason I'm showing it is two things. First of all, misdiagnosis, 44% initially misdiagnosis. But the second thing, the mean time to diagnosis, 5 years. So early detection, early diagnosis is critical, and we need to be doing that properly. We also need to be focusing much more on the role of primary healthcare and involving primary healthcare much more in our research and looking at ways in which we can do that. And it has to be patient-focused, citizen-focused, and approved research that we're trying to drive at the European level. You heard mention earlier on of the Comprehensive Cancer Centres model and the great work that's been done by OECI, and certainly the work that we did and the analysis that we did would back up that assertion, and that this does make sense in terms of working at scale, working together, looking at ways in which we can bring different communities together is really important. And one of the things I've just talked to Ebba beforehand, she's probably going to ask me this question afterwards as well. Also bringing in other areas, social science, cybersecurity. So looking at ways in which we can actually expand the community of cancer researchers to address particular challenges that we face in 2023 and beyond. If we then look at treatment, Two of the therapies that we use to treat quite a lot of cancer patients, surgery and radiotherapy, are significantly under-resourced and under-researched at the European level. Again, that's what this data shows here, and I'm happy to share more detailed data of that with anybody who's interested as well. And we're presenting this at a Swedish presidency event in Vienna in 2 weeks' time, is it? Something like that. Again, really important. 50% of patients with cancer have an evidence-based requirement for either surgery or chemotherapy, but we're not spending anything like that or devoting anything like that much time in relation to that. Delighted to hear Joanna talk about survivorship and quality of life and living with and beyond cancer, because we feel definitely that it's very critical to how we deliver better cancer research that's actually more relevant to the patient. So what we've suggested is there should be a European Survivorship Research and Innovation Plan. It should have not only a medical, but also socioeconomic and political legal. You heard from Matthias about the Right to be Forgotten, the initiative that Françoise Mounier has led. We've just published a paper recently in BMJ in relation to this. I'm delighted to say that Portugal is one of the countries that has taken on the right to be forgotten. Essentially, the right to be forgotten is something that should be part and parcel of every country in Europe, and perhaps through your European cancer hubs, your individual national cancer hubs, you can help us to look at driving that. Essentially, what we're saying is cancer patients should not be discriminated against when they are cured of the disease, and they have significant challenges in relation to health insurance, travel insurance, mortgages, etc. That is simply discrimination. Thankfully, 6 countries, with France being the first country to take the lead in this, have brought in right to be forgotten legislation, but it should be all 27 countries in the EU and also beyond the EU. And it's one of the things that we're really fighting for in relation to driving that, and we would like your help in that regard. One of the things we also looked at was a more detailed analysis of the impact of COVID-19 on cancer patients, on cancer research and cancer treatment. Just share 2 pieces of data with you. The first one, 100 million cancer screening tests not performed in Europe as part of the cancer, as a result of the pandemic, and then 1 million cancer patients undiagnosed potentially. They're really worrying figures. That sort of challenge, particularly in relation to reversing the initiatives that we've seen, or reserving the challenges we've seen in relation to the impact of COVID. We really need to address that as a matter of urgency. I mentioned the war in Ukraine, and obviously one of the things that the European Cancer Organization with the American Society of Clinical Oncology, and particularly the drive that patient advocates have had in this space, which has actually been phenomenal. But what I want to do is focus on cancer clinical trials. You're probably not aware of this, but actually Ukraine is one of the highest recruiters of cancer clinical trials in Europe. So we have a bigger problem than simply the problem that's happening in Ukraine, which is obviously extremely challenging. But we also have a problem, and as well as this data that we've shown here, we've also, if people are interested, we can show you some more data showing really the impact. So we really need to look at doing something about that, because otherwise we're going to have a big challenge in relation to clinical trials in Europe. And the other thing is we should not be insular. It shocks me the little that we spend in Europe and in the US on cancer research in low and middle income countries. And again, part of our recommendations, again based on data, was that we really need to change that. And we've been discussing this at a sort of a European US perspective as well. I talked with Julie Graylow, who's the Chief Medical Officer of American Society of Clinical Oncology, and obviously a former professor of global health as well, and looking at ways in which we can work together to do that. So just bear in mind, I've talked a little bit about money, I've talked a lot about focus, and I've talked a lot about data and how we use data to drive. But we have to remember that health and health-related research is not an expense. It is very much an investment, and we must remember that. These are the 12 recommendations. I'm not going to go through them. I've touched on most of them in the talk. What I do want to do just to end the talk is to go back to this idea in relation to data and the importance of data and data intelligence. And the timing is probably pretty good, because I think in about, let's see, Yeah, in 4 minutes' time, the embargo will be released, so I'm actually breaking the embargo. We have a paper in Lancet Oncology on the European Cancer Pulse, which is essentially looking at tracking inequalities in cancer in Europe. And it's out in Lancet Oncology today. What we want to look and see is really how can we map inequalities in Europe. And this is to complement the European Cancer Inequalities Register, but maybe to go further in terms of looking at countries that are not in the EU and also looking at some of the other parameters. So 34 countries, 120 different data measurements. The link to the site is there. And really what we're trying to do is really find data and make it more intelligent and more accessible. So this is really a tool for everybody to use. It's available, freely accessible. You can look at, see what data sets are there currently. We're also encouraging people if they want to add to those data sets. And it's essentially trying to bring all that data into one place so it can be used, it can be part of driving policy change, etc. And looking at ways in which we can really address the significant cancer inequalities that unfortunately we see in Europe. This is just showing you examples of the type of data that's present within it. If we go into a snapshot, Tees will probably have something to say about this as well. This is disgraceful. 12 out of 27 EU countries have not updated their national cancer plan, so they don't have an updated cancer plan. How are they going to do anything about cancer if they don't have a cancer plan? And leads you to think I'm being critical of the EU. I'm even more critical of the UK, who've decided that a cancer plan doesn't matter anymore. In fact, we won't have a cancer plan. We'll have some sort of a general disease plan. I saw, again, in Lancet Oncology today, Lancet Oncology today is actually very good to read. There's a lot of good stuff in it, but patient advocates have come out and said, what are you doing in relation to driving a cancer plan without a cancer plan, or cancer treatment and diagnosis, etc., without a cancer plan? It's just incomprehensible to me. And I can't understand it. We've argued with the government, we've argued with the civil service in relation to this, and we'll keep on arguing until we get them to change their mind. But you can see some of the other data there in relation to CT scanners, medical personnel in relation to oncologists, nurses, etc., healthcare spending, cancer survivorship. That's just a little dip into the data. So I'd encourage you to go on the website, dip into the data more, look at what you're particularly interested in. And as I said, we're also very keen on bringing more data into the Pulse so that we can do that. This is just the plan for going forward, again, adding more data, looking at ways we can use advocacy based on the data intelligence that's generated to drive change, develop country and topic-specific reports, which we've done in relation to the countries. We're going to be launching a Pulse 2 in the summit in 2023 in November in Brussels, and looking at ways in which we can make it functionally better. And we, again, would very much welcome your thoughts when you go on it and look at it. Tell us how we can make it better. We know it's not perfect. So we really want your input in relation to that. So just to end, we want to drive change. That's why we're here. That's why we're all here in this room. That's why you want to work together at national level to achieve what's been proposed at European level. Again, follow the data and make change happen. That's really where, if you want one message out of this, or maybe you'll remember more, data eats opinion for lunch, but whatever you do, just remember the importance of data. But the second thing that's even more important is the patient. The patient can be a disruptive force in this, but also can really drive that gap between health research, policy, and clinical practice. I'm not being critical of Joe Biden, but there are things that we need to sort out on the ground as well as shooting for the moon. Thank you very much indeed.
Thank you very much, Mark. I guess you all agree with me, if ever the 12 labors of Hercules would be rebranded to the modern age, fighting cancer will definitely be one of them. Now, unfortunately, I believe no one has the power to conquer cancer alone. And so with this motto, I would like to invite the next session, the roundtable on synergies, to see how we can together fight cancer each of us with their own competences and so on. So I invite Eva and Ian to get to the stage. They are work package leaders and on ECHoS, leading the synergies and also the mission-driven approach. And Mark, you're welcome if you want to join to the roundtable. Thank you. And also calling to the roundtable, Annabella, coordinator of ECHoS. Eric Solari will join us online. Giovanni Apolloni from the CCI for EU initiative and ECHoS partner. Manuela França from Centro Hospitalar do Porto, and here representing the project ECHoS, which is on cancer imaging. Mark van der Boek here, coordinator of the joint action ECAN, and Tit Albrecht, coordinator of the joint action CRANE. Thank you.
Yes, we sit over here.
Yes. Pardon? Yes.
So, follow the data and make change happen. What would be your first advice, Mark, to this panel, now when we are creating the right synergies between the mission hubs, finding new ways of working together, and then, of course, aligning it with the other ongoing initiatives dealing with the different submissions related to the whole disease pathway?
Yeah, I think it's finding the balance between things that you can do together as a European level, but also the challenges that you may face individually in individual countries. So it's not going to be the same exact thing is going to work for everybody. And that's why I think it's important to collect data that's related to individual countries, because there will be different challenges or subtleties that are really important to try and address. The other thing, I think, you've made a huge start in relation to bringing the community together. I know from having worked on a lot of things before, bringing communities together is not necessarily easy. But it's having relatively straightforward aims and going for it. But again, you'd probably say what he would say, that underpin it by data intelligence that guides you in the right direction.
Thank you. Before we go into the question of the synergies between these initiatives, any comments and reflections from your side here to the ground shot? Probably you've also been part of these developments and you're working on the ground in different countries. Would you like to start it, Albrecht?
Yes, I think, of course, it's good that we get the synthetic information together that Mark presented us with. I think that this is one of the challenges that I consider the Commission will have when trying to synthesize the outcomes of all these projects. Not only the ones present here, but I'm sure that you are all aware. I'm looking at Mark on my left, who is involved in very many of them. But we are all part of several projects, very important projects. Today I have just read that the joint action on cancer screening still doesn't have a coordinator, which also shows some strain on the public capacity to manage the projects. And the amount of money that has come in is now really significant. So there is the political determination, there is the momentum that Mark was actually trying to lift, to raise. What is now important is the mobilization of the member states. Because of course, a lot will have to be done at the level of member states. The declarations, the flagships, the recommendations, and so on are nice. We are trying to integrate them, I'm sure, in all of our projects. Some are still about to start, like CCI for EU very soon. It is trying to support the activities that are necessary at the national level. Because if we want to reach some of the targets, or let's say, to express myself better, to bridge some of the gaps that Mark indicated in his introductory speech, we will have to have real mobilization at the national level. Of course, we have to understand that differences in spending are important, and not all of those differences can be just neglected. The figure I stays in my mind is this spending gap between Romania and Austria. Well, even if Romania increases it by 50%, it's still going to be only less than half of what Austria is spending, and that would already be a lot. But I think that the specifics of cancer, which makes it different from other NCDs, is the ability to get cured, the ability to detect it in pre-stages, as Mark has indicated, to detect it early, and to really return the person to pre-morbid life. I think these are characteristics which we will all strive at. Research, one last thought I would like to say, because I like this accent very much, and sometimes we face some sort of hesitation on the part of some of our partners, I have to say, on Crane. There are some people who still see the distinction between the so-called routine care and research, as if these were two totally separate worlds. In cancer, they are so interconnected that you cannot say, well, this is a totally routine thing, this has nothing to do with the new research findings. There is always a link. So there always has to be the capacity to introduce research findings into everyday practice. And that's also part of what we are trying to do in our joint action Crane.
So thank you, Tit. I will continue on the research part, because this is a research-driven project. And I think it's very difficult to convince the health departments that research is a part of care. We had it recently still, where Belgium is next year taking the presidents of the EU. We're preparing all sorts of meetings, and you present a meeting that is more research-driven, and then the Ministry of Health says, yeah, but that stays out. That is research, we do health. So this is a difficult thing, and I think ECHoS should really stimulate this discussion, because indeed, there is no strict difference between, definitely not in cancer, because I remember when I was in the ICPERMET committee, I think 5 years ago, I was with Irina Norstedt discussing, yeah, but what are you now doing? Is this research or is this health? Because we had the joint discussions, and Irina at a certain moment said the limit, the border between research and care is blurry. Yeah, it is blurry, but it should not be blurry at all. So I think this is really one of the messages that you bring that I really like. The other thing is, and I had this discussion also with the Commission, we should definitely, with the EBCP, bridge with Moonshot, and not leave the UK out. But UK is probably even easier, but I understood that the discussions between the Commission and the United States is ongoing. Yeah. So I think that is really a good way forward, because especially if we are going to, let's say, personalized medicine, we will need the maximum of data that we can have. Now, speaking from ECAN, data is important, and we are starting, in fact, to look at the mobile digital tools that we have. How will we deal with this data? Because there is some concern about security. We have no idea where these data are floating. So these are things that we are addressing because that is something, and I think, Mark, you showed it in your slide when you had the links with the general practitioners. This will all be digital at a certain moment, but we have to make sure that there is secure in order to have the patients and the professionals share this data with another initiative, which I haven't heard here yet, the European Health Data Space, where trust is going to be an essential element on making it possible to have a data-driven approach.
Thank you. I will comment in a very short way the topic. I think that I have to underscore the 2 points raised by Tit and also by Mark, that the first one is about the need to mobilize health authorities at national level, because it's a step that is not considered granted. Something should be done in order to be able to transfer what we are going to produce in the context of our project at national level, because according to my experience, at least in Italy, it's not an easy task. The second point is about research, the integration between research and healthcare. And I think that the right place to do that is what we can call, even if I don't like to start now an endless discussion about a definition, a comprehensive cancer center. A comprehensive cancer center is the right place in which healthcare and research are integrated throughout the continuum of the journey of the patient, and the continuum of the research. The third point is about the fact that we cannot make the mistake to forget that Europe is also UK, but Europe is also some, let's say, Eastern European countries that, of course, already in the past, and now given the aggression of Russia to Ukraine, is a very critical point. So I think that we have to mobilize health authorities at the national level. We have to do the best research in the context comprehensive cancer center, and also don't forget a very large and wide definition of Europe.
Thank you, Giovanni. Online we have Chloe, which is also representing another important project, the for Ancan.eu. And I would like to give her the floor also to join this discussion.
Yes, thank you. Can you hear me properly?
Yes.
Yes.
Okay. Well, I'm sorry on behalf of Eric, but he couldn't join due to conflicting agenda, so I'm taking over for him. So just thank you for inviting me and having me to discuss with you today. I think one of the big challenges that we need to tackle now, and that we are actually doing, is that we need to do a shift in the culture of research. I am a former researcher, and I know that the struggle of researchers to get acknowledgement for the work that they're doing, and it only relies on the publication that they do. And I know that now the culture is changing, and people are more and more aware of the fact that if we work together, we will be stronger and we will make more discoveries if we share the data. But some people are still reluctant to the sharing of their data because they are scared of losing the property of their data and losing the acknowledgement of the work that they've been doing to get there. But I think with this mission on cancer and this all these projects that we're doing, the shift is ongoing. And just like, I can't remember who said this, but we need to mobilize the member states. And just like we need to mobilize the member states, we need to find incentives to mobilize the researchers, to share the data, and to be part of this big project that we have to tackle and to save 3 million lives by the end of 2030. And basically, I think that's pretty much what I wanted to say.
Thank you, Chloe. And indeed, working together and sharing data was also echoed by Mark in his presentation, which I think ties in very well. But maybe you would like to continue the round table?
Yes, first round of reflections here.
Thank you. Just to not repeat again what was said before, but I think that, well, with the cancer ground shots, they highlight the need for data-driven research. And I think that this is a huge task that can be driven by several European initiatives, ECHoS and others. We work with imaging data, but there are other kind of clinical data. And this is crucial to foster innovation and research on cancer.
Thank you.
Thank you.
Annabella would like to have the final word on this round.
Yes, so I think everything is very important. We have so many subjects, and I think the 1 million question is how we can manage all this together and to still be focused and achieve our goals. So basically.
Yes.
Exactly.
Yes, in fact, that brings to what ECHoS is doing. So how can ECHoS be a game changer in this landscape? So since the cancer mission has been launched, as you are aware there, and as we heard this morning, as you can witness in the panel as well, there's a proliferation of projects, all doing different things, but in some way working together and not. So the ECHoS project, when the call was published for the ECHoS project, I remember, and I was approached by Annabella and Ugo to participate. I couldn't help but highlight all the areas where synergies was mentioned in the call. And I have one impressive slide. I'm not showing it today, but Annabella knows very well about it, which really shows the detail that the call itself asked us to synergize with, I don't know how many initiatives, partnerships with projects. So the difficulty was how to contain all these synergies. And after some work, we came up with a work package. So we have work package 4 of the ECHoS projects, which is dedicated strictly to synergies. And we thought that maybe the approach we took was that ECHoS doesn't have to work in a silo. So ECHoS has to open up, okay? We are the project which is possibly very close to the citizens, very close to the member states. We are setting up the cancer mission hubs. We cannot work alone. So synergies was a central part of our project. And in fact, work package 4 is divided into 3 main blocks. We have the first block, which is for synergies with at the higher level. So there we are looking at exchanges with European Commission, European Parliament, with the Cancer Mission Board, for instance, with the Europe Beating Cancer Plan, for instance. So really at the highest of levels. Then we have an operational task. So there we have the operational synergies to ensure that there are synergies between the project. So this is the start of it. And integrated into this task, we also have a toolkit, which I think will be an important tool, not only for our project, but also for your projects, where we would like to populate with information and mapping of all the initiatives that we are looking at. It's not an easy task. I can already say this, I can frankly say this, but because there are many initiatives, many projects, and the more we advance, the more projects we foresee to come in. So the mapping cannot be done once, but it has to be a continuous process. So this is why we have to design this tool to ensure that this data flows not only for ECHoS, but also be a useful tool for other projects which are working under the Mission on Cancer, under the EU4Health program, for instance. So there is a lot going on. There's a lot out there. So we really need to work together in some form or other. And then we have another task under work package 4, which is all about cancer renewal. So everything that goes beyond health and cancer. So sometimes when you think of synergies, you think of having synergies with the Europe Beating Cancer Plan or DG Santé, or with under initiatives under DG Research, for instance, but it's not enough. What about the Green Deal, for instance? How does health and cancer fit into the Green Deal, the Bauhaus Initiative, for instance? So there we would have a dedicated task looking at synergies within that sphere. We have a slide which was up before, because I thought that for the benefit of the audience, it would be nice to have a slide where you can understand the different projects, what they are doing. Because for someone coming from outside, it's not easy to perceive this. So I think we should introduce, maybe.
Here we have.
There it is. So I will not go through them again, so they are on your screen, but I would give now the floor to each one of you to have just a 3-minute presentation on your project and what it is trying to achieve. And so just go ahead.
Yes, so if we start with Crane, one small detail, which is just an anecdote. Our project managers thought that sometimes it's nice to think that the logo and the acronym also means something. And she thought of Crane because in origami culture, it signifies, crane signifies hope. So we said, let's put some hope into the project. In any case, there's a flagship of the Europe's Beating Cancer Plan that specifically lays out the ground for the establishment of the EU network of what it is called in the flagship of National Comprehensive Cancer Centers. So there is a clear mandate for the establishment of this network, and this is the core activity of our project. Of course, the environment is rather complex. There are countries which have long-standing experience with comprehensive cancer centers. There are countries which have recently joined the club, so to speak, and the modalities of the organization of these centers vary greatly. What we are trying to achieve is to enable the establishment of all CCCs in all member states. There are obviously some challenges with the smallest ones, as you can imagine, yes. Ian. We have 2 island member states. We have a third one, which is also rather small, Luxembourg. Of course, as some people said the other day, you do not set the rules around the outliers, around the specific cases, but they are instructive in themselves as well. One of the most important issues is in networking at 3 levels, I would say. Networking at the EU level in order to reinforce the experiences, have exchanges of experiences from many countries in order to learn from these. Then networking at the national level. I was just talking in the break with Dorota about the Polish national network. So Poland, which is much bigger than the countries that I have mentioned, has obviously other challenges. And then we should never forget that we have federal member states that have a federal structure where regions are responsible for healthcare and also for cancer care. This means that there is networking at different levels. Of course, it cannot be random networking. It needs to be organized, and this is what we are trying to provide for. This has to be supported by the adequate collaborations, standards of care that will ensure high quality and access to high quality. We know that cancer has some specific challenges. For example, radiotherapy cannot be installed just anywhere. Similarly, proton therapy, which is also very complex and very costly. So for some patients, travel and staying out of their comfort zone and closeness of their home environment is unfortunately a necessity. But from my point of view, and I think also from the point of view of Crane, it is important to ensure that every citizen has the proper means to access high quality of care with adequate also resources provided for the patient in case they need to stay elsewhere, whether outside of their region, even outside of their country if necessary. Slovenia uses proton therapy of the neighboring countries, so we are also part of the story of, let's say, smaller countries. So this kind of networking is not is already a matter of practice, and I think it should be also stimulated. The other week, we had a meeting of one of our core work packages, and the question of numbers was raised. Mark likes numbers a lot, of course. He has shown many today. In modern healthcare, we cannot escape numbers. I know it causes frustration sometimes for smaller environments, but perfection is partly achieved through repetition and through experiences gained by the sheer volume of care. And this is something that we cannot run away from. This means that, of course, what Giovanni was referring to earlier is not only about concentrating research in specific institutions, but also having the volumes of care which provide for high quality and, I would also say, safety of patients treated, because we sometimes forget about this other side. It's about high quality, but it's also about safety. If this procedure is familiar to a center, safety will also be much higher than somewhere where these procedures are practiced randomly. So our ultimate goal is to provide for the definition, for the framework and definition of CCCs, the model of their networking, and also the inclusion of the networks that can be built around CCCs, where the CCCs play the supportive role in providing the environment for research and development and also training, while at the same time linking with other institutions that potentially provide parts of the entire trajectory. Because what is mandated also in the EBCP is the fact that CCCs should provide the whole range from early detection, even screening, all the way through to follow-up care, survivorship care, and supportive care, let's say end-of-life care if needed. So this is very important, and of course research can also in these other areas that are maybe less familiar to the general public can also be best provided for in such centers.
Thank you.
Thank you so much. And for achieving the goals of CRANE, how do you see that the ECHoS network can accelerate that or help? How do you see that in the synergies?
Well, for me, I think...
Being a partner also of ECHoS.
I think that this is actually a great link, especially in synergizing on the research initiatives, which of course are not, you know, in the past, I have to say, there was an anecdote some years ago with DG Santé, I have to say, when I was asked why was the representative of DG RTD present at the meeting of a joint action, because the joint action is a Santé project, not an RTD project. And today I don't think anyone would make questions like that, fortunately. I think the interlinks are very strong. The determination of budgeting for research, not only for infrastructures that enable research, but also budgeting for research projects, I think is essential. And this is what we are hoping for. And I think that training is also one of the connecting points between our projects.
Yes. And I would actually ask Giovanni to replicate directly from the CCI for EU. So we have another initiative then from the Cancer Mission for the Comprehensive Cancer Infrastructures. How do they align together, and what synergies do we build going forward?
Mark is laughing. I think that, I mean, first of all, just a short introduction about CCI4U. CCI4U is a project that is based on a very strong assumption that doesn't need to be challenged or demonstrated. Citizens patients treated in the context of a comprehensive cancer center or a comprehensive cancer infrastructure, when we will understand the difference, have a better care and better outcome. And CCI is, the aim is, CCI for you is just the creation or the upgrading of a comprehensive cancer infrastructure in each European countries. In each European countries, according to the need and the context. Because what we know we know very well that there is a huge variability in terms of economic, financial, organization, quality of care, access to care, and outcome. The project is organized in 5 steps. First of all, we need a definition of what is a comprehensive cancer infrastructure. Then we'll apply this model by profiling and mapping the existence and the maturity of a comprehensive cancer infrastructure in each member state. The third step is to design and implement a capacity building program tailored to each context. The European Commission asked us to start, first of all, in the country with the major need. It means without any kind of activity in the structure. And of course, later on to scale up and dissemination and exploitation. I think that the CCI is coordinated by myself on behalf of the European Organization of Cancer Institute. The co-coordinator is Simon Oberst, that is the head of our accreditation and designation program. And I think that there is a lot of need of integration with a lot of other ongoing projects. Of course, CRANE, but not only CRANE. And for the ECHoS, of course, what I see, just knowing some of the situation in some countries, that the right place in which to allocate the hub of the cancer mission hubs at national level should be the national infrastructure, because it is a very relevant function of structure that has the objective to optimize at a national level, at the European level, the dialogue between research care in the context that we have discussed about. We will have our kickoff meeting in May in Milano, on May 23 and 24. We have already about 85 participants, and we will try to discuss at the best how to implement our project, but it was very important for me to be present today, because we will try also, in order to reach this goal, to design and to understand how to implement our project, to make it possible to keep going this kind of synergy discussion between projects.
Excellent, excellent. And Mark, from Sony, we've chosen one of your projects to deep dive into here, but the map you showed us yesterday in the executive board meeting with all types of initiatives and how they would actually come together, where do you see us going forward?
Well, maybe just being in between Tit
yes.
and Giovanni, let me take on the head of the member state. We have to integrate both in one system. So that's there. I think the conclusion is from having a project that is more driven, I would say, by DG Santé, and that is probably more political and health related. One that comes from RTD, which is stressing more the research, but in the end, it comes together. Exactly. So that's why we are in these two projects, because I think otherwise it's difficult to bridge if you are in one and not in the other, because it becomes very unclear what exactly is being done. Now, we are indeed the coordinator of the joint action ECHAN, and I must say, if I remember the call, it was a call directly set up due to the COVID crisis, and then it was apparent that telemonitoring and teleconsultation was very important, because people could not even go to the general practitioners. Exactly. And so they wanted to do that. They linked that to cancer, because there, I guess, for DG Santé, there was the possibility to have some financing, and they put it in on remote areas. Now, there was apparently, again, nobody who wanted to take the lead, so Matthias Schuppe contacted us, asking, would you not do that? I say, Matthias, that's very fine, but in Belgium, remote areas is a bit strange. Yeah, but he said, so I discussed with both the NIHDI, who are the payers and who actually are evaluating the introduction of digital tools into the healthcare system, also with our ministry, and both said, yeah, but it interests us, try to broaden it. So we broadened it, and that's why we came in. And actually, when we started the project in October, there were 3 things that were raised by some of the representatives of the member states. Is first of all, what is the evidence of the digital tools being really useful? That's one of the things that the framework was not really so clear. The secondly, how do you reimburse that? This was a more critical thing, because is it and or and/or? And if it's and/or, yeah, that raises some discussions. And the third one was cybersecurity, security of the data, the whole data set. And then they wanted also us to make the link with the European health data space. So these are 3 topics that we will take up in this joint action. There is foreseen a policy dialogue on this topic. So I think there also, there is research needed still. So I think there ECHoS could really make a good link. Another topic that we didn't really put into this joint action is the recent explosion of artificial intelligence. And there's a lot of artificial intelligence algorithms that are going to be used, and we should get a better view on what is happening there. So, but that we already discussed with DG Santé, and there's also with DG Connect, there is a lot of things that can be done there, but there also I see a link with ECHoS, because that is a new field, and it's not only to what we are doing in telemonitoring and teleconsultation, it's in very many aspects. So that is something I think that in ECHoS should get, that we have this research community really working together and have access to everybody that is working on it. And through our mirror group, and that is more or less a mission hub already, we had already good exchanges with researchers that we were not aware of, or not of the field of cancer, but are really into artificial intelligence and direct needs. So I think these links can be made through ECHoS. We have some trials going on, some pilots that we are running, and everybody was very enthusiastic. We had 10, 12 countries participating. So you start preparing the protocols, you start to discuss, and then apparently in some countries, nothing of infrastructure is present. So how are you going to roll out your trial? So, but okay, that's why a joint action is run. It's to learn. You identify what are the needs, and then I think, Giovanni, will come to the CCI for you. You can complement, do capacity building, and help us in that. So that's something you learn there that is really true for an interesting thing. And I think for ECHoS, definitely there are very many opportunities in that field. There was a topic that we specifically didn't cover in ECAN. That was the molecular tumor boards, because everybody wanted to have the molecular tumor boards, teleconsultation, telemonitoring. But we are indeed in more than 12 projects now. I think in every project they wanted to discuss on the molecular tumor boards because it's apparently so important. There's a lot of projects on genomics. So we put it in another project, Can Heal. We're going to do the molecular tumor board in there, but I think also there may be links for ECHoS to look at that, because there's a lot of research that can be withdrawn from the things that we discuss in the molecular tumor boards.
Definitely. And thank you. And I think you brought up also that you didn't foresee the avalanche of the artificial intelligence, and I think that would bridge very well nicely now to Manuela for the initiative of the UKIM project with unlocking the power of imaging and artificial intelligence in state-of-the-art platforms.
So thank you. So I'm honored to present the UKIM project. That is a 4-year initiative that was just launched on January 2023. And, well, we hope paving the way for the future of cancer diagnostic and treatment. So UKIM is committed to take advantage of the power of artificial intelligence and medical imaging to revolutionize cancer care. At the core of our project is Cancer Image Europe. So this is a federated research infrastructure encompassing a large collection of cancer-related de-identified images from real-world data from several hospitals across Europe. So this digital infrastructure is designed to preserve the data sovereignty of providers, while at the same time serving as a platform that enables and encourages the development and benchmarking of AI tools to advance precision medicine in cancer. So the ECHoS project brings together a diverse consortium of 76 partners, including clinical data providers, researchers, research infrastructures, and industry experts, all united in our mission to address the fragmentation of existing cancer image repositories throughout Europe. So by building on existing repositories from other AI for health imaging initiatives, other European research infrastructures, and national and regional repositories, we aim to create a sustainable flagship repository of high-quality data and tools in alignment with the European Health Data Spaces Initiative. So our project is organized into 8 work packages, each focusing on different aspects of the infrastructure, ranging from data management and interoperability to AI-driven innovations and ethical considerations. So this collaborative approach enables us to foster the transition from research into clinical practice, ultimately benefiting citizens across Europe. So in summary, ECHoS will make large amounts of cancer images and linked clinical data easily accessible to European clinicians, researchers, and innovators in line with the European data strategy and supporting the goals of the European health data space. ECHoS will showcase how medical images can be accessed, used, and pooled while ensuring a high level of ethics, trust, security, and personal data protection in full compliance with European values and rules. So as part of this roundtable discussion on synergies in mission-driven cancer research and policy actions, we are, of course, excited to explore potential collaborations and to share our expertise with other projects and initiatives. And together we can drive forward the development of AI-based technologies, transforming the landscape of cancer diagnostic and treatment and improving the lives of countless patients. So for ECHoS, I think that ECHoS has the potential to serve as a common platform to bring together all these different initiatives for communication and for engagement across various cancer initiatives in Europe. So looking forward for these collaborations between all these initiatives.
Thank you so much, Manuela. And a comment from Mark, and then I would like to leave the, virtual floor or room to Chloe, also building on with the federated research data hubs. You want to go first, Mark?
I think what you've heard, is this on?
Yes.
Yeah.
Yes. Okay. I think what you've heard really is, the ability to have almost foundational data research assets and also data intelligence. I think that's the power of this. So it's bringing together all the different countries of the EU, but also bringing together significant data that will actually allow you then to look at ways in which you can work together. I think one of the things that, one of the disappointing things, and I think this is probably the challenge, so if you look at when we sort of look at new screening recommendations, remembering that we had screening recommendations last in 2003, and it took us 20 years nearly not to implement them in every country for cervical, colorectal, and breast. But if you looked at what we had initially in relation to that in terms of the recommendations that were made, they were very strong, they were complete, have at a much higher level in relation to breast, cervical, and colorectal, and then have long and then prostate and gastric. But if you look then, what happened was there was a watering down of that, and I think that's the challenge. So the challenge is, how do we at national level make sure that what we're doing that is really excellent together actually then gets translated and gets implemented. But I think the power of having foundational data sets, data intelligence, showing ability to work together, showing cross-border collaboration, and I mean real collaboration where we're actually, if you look, for example, on the island of Ireland now, paediatric cardiology is done in Dublin. So there's two different health systems working together, and it's back to what Teed said in relation to scale. Similarly, cancer in the northwest of the country is actually done in Derry in Northern Ireland for a lot of cases, rather than people having to travel down. So there's a geographical thing there. So a lot of those things can happen, but it's almost using what you're doing and doing so well to say, listen, this is the way we do it. You have to change your mindset. I think that unfortunately is going to be the challenge, but I think you're set up well because of the way you're comprehensive, but also you're bringing particular expertise and assets to the table as well.
We'll come back a little bit to this challenge of the actual implementation in a moment, but let's move over to Gustave Roussy in Paris. Chloé, would like to comment a little bit more about the UNCAN project.
Yeah, of course, thank you. So we are a coordination and support action called For UNCAN EU, and this CSA is aiming at delivering a blueprint to the European Commission with a strategy roadmap on how to implement a European federated cancer research data hub. We are called UNCAN because we want to understand cancer better. The final aim of our initiative is to reach a new level of understanding of cancer mechanisms, looking for innovative therapeutic approaches to contribute to save more lives along the years. And this we want to achieve via open sciences and data sharing. We are already on month 9 of the project. We are supposed to deliver the blueprint to the European Commission by the end of November 2023 this year. We are 20 member states involved in this project with 29 core and advisory partners. We are working in a bottom-up approach involving the patient and citizens, thanks to a work package who is dedicated to the communication and involving patient advocates into the building of UNCAN EU. We are also we have also a work package who is dedicated to identify and try to find solutions to solve inequalities in cancer research across member states. We have another work package who is involved in identifying the next European challenges in cancer research. And we would like to use, after we identify those cancer research challenges, we would like to have calls opened to fund new research projects related to those cancer challenges, with the hope that the data generated through those projects will feed the European the Federated Cancer Research Data Hub. Sorry, I'm lost in my presentation, but we want those research use cases to generate data that will then feed the Cancer Research Data Hub that we want to build. And thanks to AI and machine learning, try to identify the next research challenges and then have a feedback loop into having more and more data and try to reach the next level of understanding for cancer. And we have the ambition of gathering not only genomic data, but all kind of data regarding cancer. So it includes patient images, patient clinical data, lifestyle data, omics data, just like I said, but, and also research data such as cancer model data, patient-derived models data, coming from a lot of different structures. And the way we foresee to structure UncannyU, so the federated data hub, is to have national data hubs in each member states. So we can then federate all those national data hubs. And I think this is where ECHoS can help us have these national data hub built in every member state. And just like Manuela said, I think ECHoS can be of help in being a common platform to have all the ongoing initiatives to collaborate. We have already been in contact actually with the EUCAIM and with Ukraine, and we don't want to build UncannyU out of nothing. We want to build upon already existing infrastructures and initiatives. We don't want to go from scratch. So Hugo just said before that it's kind of overwhelming to see how many different initiatives are actually ongoing, and we have a work package with dedicated to identifying all those infrastructures and initiatives that could be of help in building UncannyU. And I think the help of ECHoS to keep this momentum going after the end of the CSA and after UncannyU is already built will be really significant for us to keep including everyone and be sure we don't miss anyone and we are not replicating the effort without connecting each other.
Thank you, Chloe. I just have a follow-up question to Chloe, actually, on the identification. Can you give us a timeline when this identification will be done?
You mean identifying all the infrastructures and stakeholders that could be of help?
Yes, yes.
So it's actually ongoing, and we already had a workshop in Heidelberg in February with relevant stakeholders that we already identified. But it's an ongoing process. Like very recently we met with Louis von Marti from EUCAIM to get him on board as well, and we're continuously
updating,
adding more and more people on the list. Yes. But we will have a final workshop in September. So we hope that by end of June and beginning of July we will have most of the stakeholders identified and on board with us. But this is something that needs to still be ongoing after the end of the CSA.
Yes, I agree. In fact, with this identification, even with the cause being published year after year, we are going to get more of these type of projects. So you need to keep yourself updated 100%. But it would be good for the ECHoS project to collaborate with Chloe and this identification, especially now that we are going to start the identification of the projects to build on what you have already started. So
of course, we should definitely be collaborating on this because I feel like it's a loss of energy if everyone is doing the same work on without communicating with each other. We have already done some of the work, so we could definitely talk to you and give you
something that we definitely should not do is replicate, and this is why we wanted this type of sessions where we can brainstorm a little bit to see whether we are duplicating any efforts and to avoid this duplication.
But also rather finding the reinforcement so we can build it stronger together. And I think the togetherness is the key in the whole idea of the establishing the national mission hubs, and that we're having this project now for the next coming years to actually build those foundations and support all the member states and to work in the national languages. In our next panel, we will come more into how we actually engage with the stakeholders and citizens. I won't go into that. But we also heard this morning, of course, the responsibility that we all have now to deliver and make sure that we deliver this added value and also finding new ways of working. So I think it's very encouraging, Annabella, to hear now for ECHoS that in every project we have also, of course, have already the synergies in terms of the people. And if it wasn't for the people, nothing would really happen. It's not just about the organizations behind signing up to be part, but it's really a lot of brilliant people and minds going there. So I would like to see also hear from you now how you see these ideas materialize for the synergies.
So I think it's like a marriage. You can only make a synergy if both parts want to make a synergy. So this will be the most challenging, yes. I think, yes. Because we will identify overlapping activities, but then we have to deal on how we will share this work.
Yes.
And we know all that we are wanting to be the leaders. That's the normal thing. We want to coordinate our project, but we still have to share the overlapping activities. And I think this is one of the challenges, that to divide the work or to say, I do this and you do that in this activity. And we are all focused. We can see that there are lots of focus on research, on infrastructures, but I think ECHoS must go much behind that, because we are not only about synergies with projects, we also want synergies with programs, and we also want to engage the citizens. And how to engage the citizens also with these projects that will make synergies with us. And this is not straightforward. We will also have to do work on that. But I would like to challenge the projects here and the projects that are in the house, that are or people that are already participating in the other projects that we know we will want to have synergies, to think about this. What kind of synergy I want to do? Am I in the will to give up of a part of my activity so I can also ECHoS give part of his activity, so we can manage to complement and to better achieve the goals that we propose, all of us to do. So, and this is the challenge for a synergy, I think, also.
Exactly, and I think it's hard to go from ambition to successful implementation. And coming back to you, Mark, and the ground shot, when you're talking about, it's about the follow-through, not just the breakthrough. And it also needs to invest also in policy and health system research and innovation and the implementation science, and also the importance that in which the social issues interact with political, technological, behavioral change. So there's so many aspects into the actual bringing the value to the patient and our societies, if we put that in mind. Yeah. What would be your advice or recommendations, or how do you see the synergies between all these initiatives and the others already also ongoing and the others to come to implement the European Cancer Plan and the Cancer Mission?
Yeah, absolutely. I mean, I think one of the things we thought about a lot was that whole area. I mean, we sort of collectively felt that Europe is very good at breakthrough, but maybe not so good at follow-through, and that was sort of informed then our discussions. And if you look at it, particularly implementation science and health service research, and if you even break them down into individual radiotherapy, say, you find that it's infinitesimal, less than 1% spend, and similarly research effort in that space. So I think one of the things we felt was there is a need to do that, to look at ways in which we can bring what are great discoveries, but actually bring them so that they make a difference for patients, they contribute to the economy, etc. So that was one aspect. And the other aspect then that sort of is, bringing in maybe sort of disciplines that haven't been, and that's where the comprehensive cancer center model comes in as well, where you're able to actually access maybe disciplines, sociology, behavioral science. For example, we need to understand why people don't go for screening. We need to understand why people don't stop smoking. We need, so there's that aspect, and we sort of touch on it, but we probably haven't really said that's an integral part of cancer research, and it's looking at ways we can do that. And the analogy I use in terms of if I'm an astronomer, I'm looking up at the sky, I can see all those stars there in the sky with my telescope, and I'm able to pick out a constellation, and that tells me this is a constellation, and it's a Crab Nebula or whatever, and I advance the science in that area. If I'm a pathologist, I'm looking down a microscope, but what am I doing? I'm doing exactly the same thing. I'm doing pattern recognition, but I'm doing it at the micro scale. If I'm an ornithologist, I'm looking through binoculars and I'm looking at the plumage of birds. What am I doing? Pattern recognition. So sometimes bringing sort of expertise from different disciplines. We have a program at the moment, for example, where we're bringing cybersecurity into health. And Northern Ireland is one of the strongest cybersecurity sort of clusters in Europe, but they've never applied it in the health and agri-food space. It's always in the digital space or the fintech space or something like that. So it's bringing in different expertise and actually working with people that you don't normally work with is probably the key to unlocking some of the challenges that we face and looking at different solutions. Because some of the things we're not getting the solutions for, so we need to think slightly differently for. But I think implementation is really important, because otherwise we get to a stage where we get to a certain level. There's somebody mentioned there about the scientific papers, etc. But do they really matter? No, they don't matter to a patient one jot. So it's how we. You want the good science, and so that's where the recognition comes in terms of the good science gets published in the good journals, and that's recommendation that the science is good, but it's the next step. It's how you then move that from the science part into the clinic, into the driving the economies part as well. I mean, I think one of the good things about, and Ursula von der Leyen sort of set this out very early in her manifesto, was the health and all policies scheme. And I think that's refreshing, and I think it's reflected as well in what Mark said, or Jeet said, in relation to different, and it was mentioned earlier this morning, sort of RTD and different aspects of the Commission working together, which unfortunately I agree with you completely. I would have had significant arguments with people who said, well, you couldn't possibly talk to that person, they're not in R&D. And I was saying, but hold on, it's right in the centre of what we're trying to do. But I think that's refreshing and changing.
And I think that's a cultural shift that's actually really ongoing. And Mark, you want to build on that?
Yeah, I was just wondering, I already mentioned yesterday in the executive board that we have a similar project to ECHoS, Orion, that is also thinking on implementation and looking on how we're going to implement the plan and the mission, how the mission can help in the countries. And we need some sort of a tool that allows that, and we recognize that ECHoS and Orion should work together. But I was wondering, Mark, you just come from the United States, and they have moonshot. Now, I remember the Americans are always, I've been working in my previous life a lot with American colleagues, and they always had plans, and the plan was there, and in fact, they knew what we were going to do. It was in the 90s. In 2022, they knew already what we're going to do on that field somewhere there. So how is the moonshot initiative being monitored in the United States? Because maybe we could have an idea. Because it's not so simple, such a complex plan as the EBCP, because one of the things that our colleagues from the Ministry of Health, I think it was 2 or 3 weeks ago, said to me, yeah, this plan is very nice, we like it, but it would be nice to have a bit of an idea what is going to happen in 24, what will be produced in 24, 25, so that we as a member state can prepare on what to do, what to expect, because you cannot expect that somebody does something if he doesn't know what is going on. So how are the United States organizing that?
So essentially sort of two things have happened in the United States. Obviously the first moonshot, we want to call it that, or moonshot 1.0, was very technocentric. Again, I've been criticized for saying this, but it is, if you actually look at it, if you look at the details of it. Has achieved things, but probably wasn't very patient-focused. And it's actually interesting because now I've talked to quite a lot of American researchers who I work with, or when I'm in the States, and that's why Moonshot 2 has been a slightly recalibration. And I think the recalibration is based on what they looked and see, well, what are we actually doing and what is that forward-looking thing? And if you look at that recalibration, there's two interesting parts to it. One is the more outward-looking. So Moonshot 1 was very inward-looking. It was, let's focus on solving things in the United States and let's forget about everybody else, to be perfectly frank. Whereas Moonshot 2 has much more of a flavour of let's look internationally. If you look at the Satish Gopal, for example, in the Centre for Global Health, there's a lot more going on. And interestingly, ASCO with Judy Graylow at the helm, there's a lot more of that going on. But I think part of it is they probably have better measurements of what's worked and what hasn't, and I think we probably could learn from that. I think that's what you're sort of inferring. But it's interesting that there has been a change in focus between Moonshot. And then if you look at the American Cancer Plan, the US Cancer Plan that Monica launched there 2 weeks ago, again, it's sort of maybe drawing things slightly back, and we like to think it's, you know, that they're focusing also on things on the ground as well. And I've had conversations, and they're interested in looking at ways in which we can, and implementation might be one of the areas where we can actually work together across the piece. I mean, obviously there are other, you know, sort of scientific discovery areas that we can and do work together with as well. But it is interesting how, so there's been a learning experience sort of there as well in the US.
We actually have quite an opportunity, I think, to work together.
Yes.
Yeah. Because as you are aware, under the work program for health, US and European institutions can participate together and receive funding both under the Horizon Europe program as well as under the US program for health. So, so there maybe there
and there's definitely an appetite. It's interesting. I would have said 3 or 4 years ago, and it probably reflects the inward looking. They probably didn't even know what the cancer mission was. I'll just be perfectly frank, okay? But the other interesting thing, like Stella Kyriakides, for example, has visited the National Cancer Institute. So again, there's those conversations going on at that sort of higher sort of level as well, which I think is encouraging. But I think there's great opportunities. I mean, I'm slightly biased because the Irish-American connection is quite strong, so we have a lot of initiatives that are working together specifically between Ireland, Northern Ireland and the US.
Well, that's perfect, because then we can piggyback on you. And now over to Giovanni. Time is running up, so...
30-second comment.
Yes,
I think that
please.
at the very end, all this project will produce new evidence, maybe new guidelines, new recommendation. We will be able to increase the number and the capacity of all the stakeholders to understand the need in order to make a step change in the future. But there is this is something that is, let's say, necessary but not sufficient, because I think that what we lack is a tool to mobilize and maybe to force national health authorities to implement this. Moral suasion and a lot of new knowledge it is not enough. And the good example is the lack of implementation of, we already know about primary, secondary prevention. I mean, in the future, we have to find the way to force our national health authority to implement this kind of new initiative. But I don't know how to do that. Moral suasion, new evidence, recommendation is not enough.
Perfect. I just want to close back with what we heard this morning about the missions, the added values, about the new ways of working together and the new methodologies to break the silos. And I think this initiative with ECHoS is a way of preparing ourselves for that. And I think missions require a different approach to leadership, one that involves working with new partners and stakeholders across disciplines and sectors. It may also require then the creation of new structures with shared ownerships, a new kind of leaders. So we should have that in mind with us. And probably we need, just like the development in Denmark, more of mission managers also in our countries and through different initiatives and with all our submissions driving, so that we can drive this long-term change for a wide range of stakeholders. And I think this could be a trigger back to the next discussion on collaboration. So, having said that, I would like to thank you all for participating and for giving ideas on hints on synergies and how we could use ECHoS as a common platform to collaborate across Europe and beyond. Thank you.
Thank you.
Thank you. Okay. Thank you. Thank you. Thank you. Thank you. Thank you. Thank you. Okay. Perfect. Well, thank you all for staying for this first half of the afternoon. We are now going for coffee break. Just before we go, we have this housekeeping that you already know. Just to remind all the partners from ECHoS that we will have our bus for dinner arriving here at 7 o'clock in the afternoon. All the non-ECHoS partners are invited to stay here for the debate that we will have after the end of the kickoff itself to see the debate. And now, without more ado, I invite you to break the silos and network in the coffee break. Thank you very much. Test. Good afternoon. Welcome again to the kickoff meeting of ECHoS. I hope you all had the opportunity to stretch your legs, maybe get some sun from outside. And now for the second part, we are 10 minutes delay in the program, so I would not take much, but just to say we had the opportunity to go through the high-level strategy in the morning on cancer, European, national. We had the opportunity to look at the data and discuss what each one of us can do. And now everybody was speaking about citizens' involvement, policy dialogues. We need to involve the citizens. How can we actually do it is the questions. It's not just about wanting to, it's about doing it. And in that regards, I believe there is no perfect, no one better to talk about it than Dr. Deepa Rajan. She received a medical doctor degree from the University of Göttingen in Germany and did her PhD in traditional medicine in India. Dr. Rajan has been working for the World Health Organization in Health Systems Division and is currently serving as Health System Advisor to the WHO headquarters and collaborating with the Observatory on Health Systems and Policy. So the Observatory is hosted by the WHO Europe headquarters to support and promote evidence-based health policy making. So Dr. Rajan, it's our pleasure to have you here. Thank you.
Okay, thank you, Hugo. And I'm really pleased to be here today. My name is Deepa. I'm with the European Observatory for Health Systems and Policies, as Hugo just said. We are a hosted partnership within the WHO ecosystem, and you can see us as a sub-office of the European Regional Office. And as Hugo mentioned as well, our mandate within the WHO ecosystem is this evidence to policy link. So this is our sort of raison d'être in that ecosystem. It's our daily bread, so to speak. So I'll be talking to you today about the science of policy dialogues, including the science of bringing people together, people, communities, civil society. I realize that the term here used is citizen engagement. At WHO, we tend to shy away from the word citizen because it can be excluding of certain groups. So just to give you the explanation of why in this presentation, I may not use that term, but I think we all mean the same thing. It's about bringing in the voice of people, the voices of communities, and the voices of civil society in the work that we'd like to do within the remit of this ECHoS project. So next slide, please. Okay, so what are the objectives of the policy dialogue? And this is something I think it's good for us to really think through carefully. Usually it's to support decision-making, or at least that's what we would all say, right? That it is to support decision-making. There's the word policy in policy dialogue. However, sometimes that decision is not so immediate, and so your objective is rather to facilitate discussion in view of keeping a topic on the policy agenda, and in view of keeping it on the policy agenda while waiting for that window of political opportunity where it then can jump potentially into that decision-making space. Oh, thank you. But to do so, to really make sure that it does support decision and does facilitate the kind of discussion you want, a key aspect is really, it's about customizing the evidence for the specific question or the specific group. Let me see if I can do point, okay. And so now when we talk about the specific question or group, this is not something that's always so obvious. This is something where we spend at the observatory quite a lot of time working with stakeholders, with policymakers in a very iterative process to pinpoint down in great specificity what exactly that question is. And then the stakeholders and the group then become much more clear around that policy question. And I'll give you a few examples to make that a little bit more concrete in a few minutes. So we use this definition for policy dialogue at WHO and at the observatory, and I've sort of red-fonted some of the key points. So firstly, it's providing a defined group of policymakers, ultimately, even if that might be time-wise further away and not always immediate, from a country or subnational entity with tailored technical evidence. So tailored is really key here, because if the evidence is not tailored to the specific policy question and the specific policy cycle stage a country is in, it's not going to be taken up in policy. It's not going to necessarily be heard. And this is much easier said than done. There's a lot of academics in this room. We have 2 research hubs, one in London, one in Brussels, in addition to our secretariat in Brussels. Sorry, one in London and one in Berlin. And we work a lot with academics to take the research that they do and tailor it very specifically to the policy question at hand. And it takes a lot of back and forth, not only between us and the policymakers, but also with the researchers, to really understand what the policymakers' needs are and to tailor that, tailor the evidence and the information in a language also that is understandable to policymakers. And the other key point in this definition, at a set point in the policy cycle. So all of the evidence that we want to feed policymakers or bring to the policy dialogue table needs to be also tailored to the point in the policy cycle one is in. So this is it about immediate policy uptake, inclusion into a particular law, into a particular policy, or is it more about implementation or implementation issues? And all of that plays a role in the kind of evidence that we use and in the way we tailor it. And this lower paragraph is more for cross-country policy dialogue, so it's about providing a group of policymakers from a group of closely aligned countries. This is in order for a policymaker in country X to feel as if they are, that the information that they're hearing from country Y is comparable to their situation. So you want to bring countries together that have either similar health systems, similar income levels, or whatever similarity that we decide it makes sense and is relevant, perhaps similar cancer hub structure, for example. Can put Nordic countries together, Baltic countries together. These are just some examples. And then the rest is more or less the same. So at the observatory, or OBS as we say, the key principles for us when we do policy dialogues, and we do lots and lots of policy dialogues with our member states, is one thing is to maintain neutrality. Now what does this really mean? Because, of course, there's always some sort of principles or set of principles underpinning a lot of the evidence in the way that the evidence was generated or collected, of course. But nevertheless, neutrality is to present as far as possible the evidence from different viewpoints and different sides of the policy questions as far as it makes sense, and to not overly try to advise or influence. So as a facilitator, which is usually the role that we take in these policy dialogues, we go through to great lengths to present the different arguments that are available. And it's also, part of it is about creating that safe space for discussion for policymakers and having tailored evidence. So some of the characteristics when we do our policy dialogues is firstly small groups. That's important because otherwise you don't really have frank discussions. Larger groups tend to then exclude certain people from being a part of the discussion. So really smaller groups are much more useful. We're talking max 30 people, and that's already a big policy dialogue, ideally something around 20. We want senior figures because we want those who are actually able to influence something at the policy level. So here, ideally, we come in with the policy dialogue when we have a real dilemma or a decision point. So a decision point is when it's really something more urgent, something more timely. And a dilemma might be something that is an ongoing issue for which there might not be a decision right away, but it's something that does need to be discussed, which is felt as a clear problem that needs dialogue. And as an example, recently I was in an Eastern European country for a policy dialogue, and it was about the health workforce and the fact that most of the health workforce were going into specializations and there weren't enough at primary care level. So not enough generalists, too many specialists. Now this is an ongoing issue that was there pre-COVID, got exacerbated by COVID, and is now a little bit at an inflection point. But policy dialogues with the same country had happened pre-COVID on the same topic, which had kept the agenda on the table. COVID then, of course, brought it to the fore, and then now the policy dialogue was about making a potential decision. And part of the reason why the policy dialogue was even possible was because A, the topic had been kept on the agenda through the various dialogues and other initiatives, of course, that had gone on in countries. And because of that, there was a good body of evidence. And then, of course, the COVID crisis sort of catalyzed the point to where a decision hopefully will be taken soon. Yes, and of course the assembly of evidence and experience. Now I'd like to hone in a little bit on the word evidence, because when we say evidence, we, on the one hand, yes, we mean sort of the more classical research evidence coming from universities, like from our research hubs, like what a lot of you are involved in your home institutions. But I think here we also need to talk about evidence that comes from people, communities, and civil society, implementation evidence, implementation research, the lived experiences of people. In an ideal world, it's documented and we can bring it in through the hard evidence, so to speak, because it's been analyzed, documented. Sometimes we don't have that. And in that case, we need to bring those voices in directly through those people themselves and find a way to make sure that those voices and those experiences from, especially on the implementation side, are also heard, and that needs to be counted in as evidence as well, especially in this context where we're talking about implementation of plans and policies. So in practice, you start from a policy perspective with, extreme customization. This is really where we spend a lot of time before even the policy dialogue happens, is, tailoring that policy question. And an important point here is that, obviously policy dialogues only work if they want them, but you can make policymakers want them. This is part of the issue, and this is where that iterative back and forth is really important to get the policy issue on the table, to understand what that policy question is, and to lead, the point being just to lead to an understanding of what that win-win is. Part of it is about the entry point, because sometimes you need to find the policymaker or the institution where, who does want that topic to be discussed. And identifying the right entry point, you will be surprised, is often not as easy as you think, or it's not always, the entry point institution is not always the obvious one, put it that way. You would need some iterative back and forth on that. Example or case in point, a few years ago, the European Regional Office of WHO was involved in a citizen health assembly experiment over 2-3 years in Israel. Now, that health assembly discussed inclusion of certain conditions into the health benefit package of the national insurance, and it was quite successful. Citizens loved it. Ministry of Health, that was mainly organizing it, loved it. In the end, however, the institution that actually has the mandate to put together benefit packages is a complete different institution altogether. It's not the Ministry of Health. They were only marginally involved. So in the end, this very fancy health assembly model, which worked quite well, didn't really lead to any policy uptake. So getting the right people, institution, and having the right entry point is actually very key, and it's not always the obvious one. In our world, when the follow-up to the dialogue is often through WHO, sometimes also through the European Commission in terms of member states implementing, some of the follow-up to the dialogues, and I think here we need to look at tomorrow in more detail how that implementation and follow-up would happen within the national cancer hubs. So in terms of the how of policy dialogue, really it's about this iterative process, to hone in on that very specific sub-issue which needs discussion and a solution. So let me go back to my Eastern European country example. In fact, when they came to us first about this policy dialogue, the issue that they came to us about was slightly different from this generalist specialist issue. They came to us saying, look, we have a huge problem with out-migration. Our doctors and health workers are all going to Western Europe. And we need to have a policy dialogue about this. We need to speak about this. And once we started having this iterative back and forth with the ministry, we realized, well, look, if some of those issues you need to resolve at a European level, would a national policy dialogue really make sense? If so, what are the national level issues that we could talk about? And there we need to talk more about retention rather than recruitment, because recruitment has a time lag, but retention, that's something you can do now with the health workers that you already have. Then we realized, okay, if we're talking about retention, there's another institute besides the ministry that needs to be involved that has a mandate to work on this topic. So we brought them on board. And slowly with the iterative back and forth, we honed in on this issue of, well, the main issue is that primary care is in crisis because all of our doctors are going into specialization and we have nobody, even in urban areas, doing primary care. So as an this is really just one of the examples about being very specific about the issue of the policy dialogue to really get the kind of results that you want, which is, being heard by policymakers. Okay, so this is what I mean by going beyond the initial request and working out what exactly the issue is, what's behind the questions. There's a number of questions here that we ask ourselves. This is sort of our standard checklist that we go over in a group and internally to try to work out and hone in on that policy questions. I think an important point we should bring up here is, if particular participants will or will not be there, does the conversation change? Because the reality of the situation is in the time period that you have going back and forth with policymakers and others, is that time passes. Sometimes we have elections, sometimes government changes, or some crisis happens, and often you are in a situation where the stakeholders do change, participants change, and that might mean that the conversation changes, and it might mean that your question needs to change entirely. And so you need to kind of be ready for that and be flexible. And this is sort of the nature of politics. So one thing that we do is usually a sort of stakeholder mapping, especially in terms of who's taking decisions and which people or institutions are taking decisions, and then beyond that, who's influencing decisions already in the policy space. And this is heavily influenced by their own roles and capacities and familiarity with the issues, interest, attention span, etc. And one issue here to maybe think about is that sometimes, depending on how much time you have, some of these things can be addressed. If you have time, you don't have to rush into the policy dialogue. You can sort of spend some time working on this first before you get into the policy dialogue. And that investment is sometimes really worth it, and that we've seen in several instances in our experience. So key points of the how, I think I've gone through most of this, but I'd like to, so we've gone through the context, defining the question, identifying the stakeholders, and then I'd like to look at these two last points. Especially facilitation is really key. Facilitation with sensitivity, especially in our world, really managing academic inputs. In our experience, academics are obviously academics, and there's a certain will, and interest, obviously, to present, the academic work, but trying to get that and tailor it and channeling it into something that is policy relevant and response to the policy question at hand does take quite a lot of work and sensitivity as well. The other issue with facilitation is, especially when you're doing facilitation which involves mixed groups with community involvement, civil society, even the lay public, this is where facilitation is really very, very key, because the public, lay people, community, civil society, they come into these dialogue spaces with a huge negative power balance. So health workers, government cadres, researchers come into these spaces with a certain standing in society, with a certain position, a certain title, and already have a legitimacy with their positions and their standing. Now, and the other thing is they all come in doing this as part of their day jobs. Now, civil society, community groups, they come in, that most of them are volunteers and are doing this on their own time. And secondly, they come in with no inherent legitimacy. So how the format and design of a dialogue space and the way facilitation happens is what is going to really go a long way in lending legitimacy to these groups. And sometimes it's small format and design issues. It's about speaking time for some of these groups. It's about putting them up front. It's sometimes, if you know that in some contexts with indigenous groups, etc., it might make sense to do separate consultations with them beforehand in a homogeneous group, because they feel much safer speaking with people who are like them, and then to bring that, to have that first, and then bring them into this space separately, and their voices separately sometimes make sense, but this is something that needs to be thought through quite a bit. And the facilitation during these dialogues is also very key to ensure that through the facilitation, through the format and design, that power balance as much as possible is evened out. Obviously, we're not going to solve societal power imbalances within this space. What we can do is ensure that we acknowledge it, understand what it is, analyze it, and do what we can through format and design elements of the dialogue space to mitigate and counterbalance it as much as we can and as much as possible. So, again, dialogues sit at the intersection of multiple overlapping influences, and we need to keep that in mind. So policymakers are most likely to use evidence when they trust the source of evidence. So this means, as far as possible, we try to link with local universities, local researchers, because these are people who policymakers already have an ongoing relationship with often, and this really helps. This is an important point also, that policymakers feel able to judge the quality of the evidence, but this is about how well we tailor the evidence and how well we present it without too much jargon and in policymaker language and simple language, and engage with them to ensure that they do feel able to judge the quality of the evidence. And of course, if it fits with the beliefs, values, and interests and political goals, it's obviously going to be much easier to have policy uptake. So sometimes, in many countries, we often hear from our counterparts in the Ministry of Health, okay, let's wait for the election because we might have a left government, for example, and then we'll have easier policy uptake. This is obviously, a key point. Again, so talking about facilitation, as I said, this is really about creating a sense of the safest space, especially, not only for the decision makers as well, the policymakers, but especially if we include, citizen engagement, citizen groups, and civil society. We want to focus the discussion. This is often where it's the academics that we need to tend to get into focus often with the discussion, and make sure that it really feeds into very specifically that policy question. Bring in the different perspectives without intruding. This is the issue of neutrality, and the team, the facilitator and the team, is really responsible for negotiating the dialogue. So this is sort of the role that we usually take in policy dialogues, and this is what we do quite regularly. And we have our checklists and things that we try to think through very carefully while preparing the policy dialogue. Now, I think we need to also be humble and understand that this will, in the end, the evidence will only ever be one part of the decision-making process. And this is why working very closely with stakeholders is key to understand what are the other inputs and where does this fit in so that the evidence bit and the policy dialogue bit can really have maximum impact. So I'll spend my last few slides speaking particularly about engaging with populations and communities and civil society. And we can see them either as stakeholders in the policy dialogue itself and include them into that dialogue space. It may not make sense in all places. It might make sense to do separate public consultations or civil society engagement separately, and then do the policy dialogue separately. It really depends on the policy question, etc. And so we look at three modalities, and one is sort of broad public consultation, so really directly engaging with the lay population, which might make sense, for example, for topics like screening or topics that really affect everyone. And then there's specific and targeted engagement with what we call the affected population. So here we're talking about, in this context, cancer survivors or people or caregivers of cancer, of people living with cancer, and then through civil society as well as intermediaries. So populations and civil society can also be, so on the one hand, we can include them in the policy dialogues, we can do separate consultations with them. We can also see them as stakeholders in the cancer mission hubs in the sense of having sort of fixed seats, if you so will, in the design of these hubs and in the, for want of a better word, I'll just say board, or in the inner workings of the hub as it is. And I think this will really depend on the country in question and how, what the cancer landscape there looks like. And of course, there's a number of reasons why you would want to engage with populations and civil societies. I think these are quite obvious, and I won't go through them in detail here. But one thing that I'd like to just mention here, so there are different kinds of participatory mechanisms to reach out to people. And, these are some of the different ways. You can do open for all forums, and the objective here is to get as many people as possible, so a larger sample size is kind of open to everyone, to capture diverse and divergent views. There are many formats here with different labels: citizen assemblies, forums, public hearings, open mic events. The thing to keep in mind here is that the people who will come will often be self-selected, so you will miss out on some people. So the best thing really is to do a mix of the different modalities in order to really get all of the different kinds of groups that you wish to capture. Then we have consultative mechanisms, which is more of an attendance by invitation, which we're in the public health space. We're very used to doing. Ministries of health do this quite often. They are in their comfort zone here, where you include representatives of population groups. Policy dialogues can come under that rubric. You have deliberative mechanisms, and here it's about carefully selecting participants, often members of the lay public, to deliberate on something quite technical. And so to do that, you need to prepare them very well and give them access to experts, and work with them to get them at a level of a quasi-expert in a way to then weigh in on some fairly technical decisions. So this is often used, you might be aware, in the HTA, the Health Technology Assessment space, for example, but also there are other examples. And then we have formalized mechanisms, and this is something that can be done within the remit of a cancer hub at a national level, is to give fixed seats for a civil society. So it's more of an institutional method. And an example is actually right here in Portugal. There's a National Health Council, which is an advisory body to the Ministry of Health, which has, I think, about 30-ish members, and 6 or 7 of them are civil society, are fixed seats for civil society. Then there's about a third for health worker associations and a third for government representatives. And so here you need to think through, okay, I mean, what's the number, what's the balance that you want to give with civil society vis-a-vis others? You know, do we have a rotational mechanism? How many years are they allowed to sit on this, on these councils and then rotate in or out? Do you provide fixed seats for certain groups, subgroups in society, because you know that they are, for example, have particularly bad outcomes in terms of cancer, so you might want to make sure that they are always part of these fixed seats. So there's a lot of questions there that you need to look at, but that's one way to also include them. And again, the best way is to mix and match across all of these, because there's always pros and cons to every method. So again, these are some of the issues to consider when it comes to engaging with people. And I just want to highlight two publications. These are WHO publications that I led when I was with WHO headquarters, where I spent most of my career until I joined the observatory last summer. But therefore you can find them on the WHO website. One is on policy dialogue, a briefing note, and this is a guidance book that we put out for member states on how to more effectively engage with people, communities, and civil society. Otherwise, I would be remiss to not say, if you want to sign up for the Observatory e-alerts to this year, the 25th anniversary of the Observatory. So we have lots of publications, events, webinars, etc., including on the topic of policy dialogue. And if you scan this code, you can get onto our mailing list. So thank you very much.
Thank you very much, Deepa. A lot of things to consider here, indeed. And next, we will put multi-stakeholders with one of the largest roundtables that I've actually attended. And it is my pleasure to learn more about the perspectives of these different stakeholders. And I should say it's not an exhaustive list of stakeholders that we have here. It is my pleasure to call Marius Gianta, President of the Center for Innovation in Medicine, and Eva Joly from the Karolinska Comprehensive Cancer Center, who are, respectively, coordinating Work Package 3 and Work Package 6 of ECHoS, and with the aim to engage people, more than citizens, people, and organizations. Joining them on stage, I invite to join Bettina Riel from the Melanoma Patient Network Europe, Christine Chaumian, a member of the Board of EU Mission, Edith Morozi, there, from the National Institute of Oncology in Hungary, Ivana Catano, a chair for the EFIA Oncology Platform, Shetil Widerberg from the Oslo Cancer Center, Richard Price from the European Cancer Organization, and William Gallagher from the All Island Cancer Research Institute. Thank you all for joining.
So, first of all, thank you so much, Hugo, Annabella, and the rest of the fantastic ACIP team for having us here, for having us trying to share this, as you say, very extensive panel. And it's really our privilege to try to do this as inclusive and also interactive as possible. I think that this excellent panel, with all of your broad perspectives and of course profound expertise in your specific areas, and also you have a lot of experience both nationally and also working on an EU and international level. It will be very interesting to hear your reflections on the subject that we are now covering. And we are talking about multi-stakeholders engagement and citizen engagement. And now, after this talk, I'm a bit afraid of using the word, but anyway, we can talk about people. of course, because that's the main focus here. But I leave the word to you, Marius.
Yes, thank you so much, Eva. Very happy to be the co-moderator of this panel, and I will start by sharing a story from 2016 when we were all nervous. I'm coming from Romania. We don't have now also a national cancer registry, and the big question at that time was, how many patients do you have? And our idea at that time was to ask people, to ask people in a national-wide representative panel to receive this answer. And the answer was that about 5% received the cancer diagnosis at a certain point during their lifetime. About 21% had a close family member diagnosed with cancer. And yes, I think the impact, we have been able to identify a big impact of the cancer. But we also identify other phenomena like infodemia, and I can explain about this, a high grade of fatalism, around 48% in 2020 of people living in Romania believe that cancer diagnosis means death in a few months. This is not, of course, true, but this has an impact. So somehow intuitively, we thought that it's important, to ask people to deal with the society. And less than 2 years, I had the chance to discuss with Christine, who actually shocked the audience in our conference, saying that now it's time for the next level of engagement and the engagement with the citizen. So I said, oh, this is our moment. And I fully agree, Christine, that it's time for the next level of engagement, but how to do it?
Oh, thank you, Marius. So I think what's my own experience is that even though, as you know, I'm very well experienced, very old, and I've lived through quite a lot of things, and I always say I know everything and I know what to do, and I say I give advice, right? But once and again, like you're saying, Marius, I find myself in a situation where the answer was not at all what I would have expected. And I always, maybe the people who know me have maybe heard me say that it was a research program, so it was a research, right? Which was conducted amongst people to know whether they preferred to have the nurse answering the phone for information or whether they preferred to have the answering machine. If you want this, dial 1, if you want this, dial 2, and etc. Right? I automatically thought that the patient wanted to nurse the contact. But the research evidence came out that the people wanted the answering machine. The answering machine put them at ease. They could listen again to the message. They could ask somebody living next to them to listen to the message. They could dial 1, they could dial 2. So, as I said, as intelligent as I am, I've had numerous information of this type. And so if you do not engage, work with the people, but it's the same for the health authority in France who convenes the reimbursement. Right? If you come with your drug that you want to have reimbursed, but the researcher or the pharma company has not performed the research and provided the evidence that allows the funding body to understand and to be able to say, yes, it's an added value to the current treatment, and yes, I will reimburse to that and that level, then you have to start right again at the beginning. So it's the same whether it's to engage people or to engage the stakeholders. You have to have them around the table, and you have to ask them what they want and what you want exactly to be able to provide on the same level of dialogue. And I wonder why we're having all this discussion after listening to Deepa, because I mean, I think she provided so many things that I have lived through, and I strongly believe. What I face as a difficulty, and I'll stop now, otherwise Bettina will start hitting me, is that most of the time we ask the policymakers at the table. It's not them who come and ask us to do something. So we're starting on the wrong foot for the dialogue, but I'll stop there.
Bettina.
Thanks. So I am leading a European patient organization, and to build on what Christine said and to reflect a little bit on Deepa. So I agree with you. I mean, I wished I had seen that slide deck like a few years ago, because it would have really helped. I think in addition to that, what is cancer specific for us is I would make a distinction between organized and not organized civil society. Because for me, this is way too passive. So I'm leading a patient organization. I'm not going to wait for someone to come to us to give us a seat at the table gracefully. So that's not how we interact in the organizations. So I think for the cancer space, we have to, it makes a difference whether you have an organization that, for example, builds own capacity where people contribute. The Romanian Cancer Plan had patient advocates in there. They have contributed actively to the work. That's different than when you wanted, for example, to see whether a patient prefers an answering machine or a nurse in the interaction. So in my mind, these are two different groups. So I think that is, I believe we have to tailor that to our very specific setting. So look at what we have, what's specific for us, and then work with that.
Well, thank you. And I think as we are here because of the ECHoS, the Cancer Mission Hubs, and as work package lead, these are questions that we really are addressing right now, and also the definition of what is citizen engagement and what are citizens. And I was thinking of having heard that, of course, the Cancer Mission Hubs the key focus will be citizens, but also that citizens will be part of the architecture of the hubs. So, Ketil, would you like to elaborate on that? Because you're also part of the board and part of the ECHoS.
Yeah, so we are here to make mission-oriented structure in EU reality, right? That means, and that's not being done before. So it's not really something we can read in a book or see in other projects. How is that done? And I think that this is based on that idea from Maria Mazzucato in US, and also based on how the national laboratories in US build up missions to solve big societal challenges. And the one thing we are gathered here today is cancer. And we all work on that in different areas. And Christina, I follow your thinking that a company needs to be prepared, but I would also challenge the view that do the company need to sit and deliver the whole package? Or should we find ways where the company work together with government to see what kind of data do we need to ensure that this drug or this procedure of diagnosis or this early detection is possible to implement in society, and also is economically viable. And I think that for us, ECHoS is a project with 3-year financing. We also need to think, how do we put up a structure through ECHoS that a European politician says that this is a structure that reflects the mission idea. They don't know what it is, we neither. And how can we build on that? And to me, that's also to show how can we in Europe bring something to the international scene.
Mm. Yeah. Mm. Okay, yes, yeah. William, please.
Yeah, first of all, I'd like to congratulate Hugo and Annabella for, the success in the ECHoS program. I suppose from my perspective, I suppose what I'm hoping to achieve, in terms of the program, you see the different models where it works and doesn't work in terms of interaction. So I'm here representing the All Ireland Cancer Research Institute. So this is a kind of grassroots effort involving a number of different colleagues in Northern Ireland and the Republic of Ireland, really, I suppose, trying to bring the best talent in terms of both cancer research, care, but also the broader ecosystem together. So I suppose a key part of, we started this about 3 years ago, was really making sure that all the stakeholders are involved, not just from the academic arena or the clinical arena, that we have strong participation at multiple levels from industry sector, patient organizations, but also, people who have, not just patients, but also people who have, say, carers or other actors in the system, but also a strong engagement at a political level. And I suppose what we've done is worked hard to, we have to tailor our approach based on different communities, and I think that's something to indicate. So one of the things that we've worked very closely with is the Patient Voice in Cancer Research, which is an effort driven by a colleague of mine, Professor Amanda McCann, where you essentially have I think it was mentioned in a previous talk, this power imbalance, classic power imbalance in terms of, when we talk about patient engagement, it's almost like you're looking for the patient to come in, but it's not, there's an incorrect kind of power differential. And so with the Patient Voice in Cancer Research, it's driven by the patients, and then actually research is kind of a secondary aspect. And one of the things that we see is commonly, and I think it was talking to self-selection, we see this problem in terms of patient input, in terms of cancer research. It tends to be the same people that are generally involved in that process. It tends to be a certain socioeconomic demographic, and trying to reach out into those other communities. I'll give you just one example. So I led a program, a breast cancer program, large-scale national program, and funded by a charity. And we were nearing the end of that program, and we actually said, okay, let's do a public outreach event. So we said, okay, let's get outside the university. We'll do it in a kind of park, Stephen's Green, very, very nice area in the centre of Dublin. And we had a bandstand, old Victorian bandstand, and we kind of, it was kind of like a family event. So we were doing this, and then this person came up to me, who was a homeless chap, and he said, what are you doing? I said, I talked to him about what we're doing. And he said, look, see this chap here, who was essentially another homeless chap, he has cancer. Mm-hmm. And so when we talk about engagement, this individual, is not going to be contactable by email or, Twitter or social media. How do we engage people who are marginalized? I might come back to that a bit later, about ways to do that.
Well, thank you for sharing that. And I would like to turn to Edith now. And your perspective is from a comprehensive cancer center. And please.
Yes, I'm Edith Marosi from the National Institute of Oncology, based in Budapest, Hungary. We are a comprehensive cancer center accredited by the OACI. So at our center, care, research, and education goes hand in hand, of course, as at comprehensive cancer centers are based in these pillars. And within education, patient education plays an important role. And as Christine mentioned earlier, that we need to talk to the patients in their own local language. But besides that, health literacy needs to be considered across the various regions in Europe. There are great differences and gaps in health literacy between Western European countries and Eastern counterparts, and also within the countries there are differences, so these should be considered when creating the messages that we want to reach the patients with, in either format, whatever format we use.
Well, thank you. And I think we will continue to involve all the panel now. So please, Ivana, your perspective and thoughts about this.
Thank you. And yes, I am Ivana Cattaneo from Novartis, representing here today the FP Oncology platform, FP being the industry association of the pharmaceutical company. And maybe if you allow me, before going into the topic, I really want to thank the colleagues from Portugal and from ECHoS for organizing this. It takes me back in time, because when the cancer plan was presented, was launched, I remember we were used to say it will come on a Portuguese caravel, because it was under the Portuguese European presidency, and that was. And today, very happy to see that the mission is landing on the ground. So you are right, Christine, we should celebrate, and it's landing here with the cancer mission hubs. I think really the mission, it's giving society a huge opportunity, starting from cancer, but then it's something that can be there for every disease area. And it's given really the opportunity of convening together stakeholders with different expertise, different knowledge, different viewpoint, something that we didn't have before. So we have to be proud of this. At the same time, I think we have to realize there is a change. And sometimes I'm thinking in my head, are we really living through the change? So are we really understanding the spirit of the mission, which is also to do things, let me say, horizontally, connecting expertise, we discussed it before, or are we keeping working with the silo mentality? So a normal citizen would distinguish from a normal horizon funding and a mission funding. And that's even worse, because a normal citizen would know that we are here discussing all this. That's something that really gives me a hard time in my head, because there is a lot going on, but still we are in an echo chamber. We are in our ivory tower. So I think, and then I'll pass because I'm curious to know your opinion, guys. I think if I look at the target of the mission, so save 3 million lives by 2030, it's already 2023. We have to hurry up, and we are doing that, no criticism. But is hurrying up enough? So we do hurry up, keep working in the old way. Will that produce a different results? Or yes, we have to hurry up, but we also need to change the way we do. We change mindset. To me, it's like if we have to go together through a collective change management process in a way. And I may comment more on this, but I'm curious to know what the other things.
Exactly. Well, thank you. And I think that the how will be something that we continue on. But Richard, please, if you want to, yes.
Sure, I'm here representing the European Cancer Organization. So we are an umbrella federation of 42 primarily healthcare professional organizations at European level. And so we spend our time in Brussels with the Commission, the Parliament and others, living, breathing there. We're sort of creatures of the Brussels bubble. So it's great to come to an event like this and meet real people doing the plan, doing the mission and making it happen. And I'm completely confident ECHoS is going to play a very important role in that. But from what I've taken today, I think there's another element going from Brussels to national and then to the citizen. And we've got a new challenge now, I think, politically, of potentially fatigue with cancer policy, that we've got all of these initiatives, everything's happening, what more do you want, sort of question when it comes from our parliamentarians or political decision makers. And I think we're not selling something boring here. Cancer research is exciting. It's in most papers most of the days. And I think we need to maybe set some quite strong ambitions about how we can connect with the public and get their broad support for what's happening and make all of this highly sustainable. So I think that's maybe something I'll take from the meeting and come back to ECHoS with other ideas.
Well, thank you. And I know you're eager. Kjetilse, please.
Yeah, I follow what you're saying. I think that an interesting thought is to say, what can we provide? So if you look at Europe as we represent here today, more as a company in a sense, and what's the competitive advantage to the global challenge of cancer? And for example, in Europe, we have national health systems in most countries. We can follow patients all through the life, and we have a population weight set. So this enables us to do research, also to develop documentation, what treatments works, what doesn't work, much faster than most countries, if we go for it. So for example, currently, FDA is the standard. But FDA do not have the data that Europe, through our healthcare systems and GDPR, have. So if we present this is a pool that we can use. And if we use now, we spend a lot of energy now to set up a European health data space. Maybe one goal of that health data space should be to develop diagnostics and cancer drugs in average 5 years instead of today's 10 years. then we have a goal, how we can use that health data space, and we provide a reason. This is not only to again, target the cancer case, but this is for you as EU politician and for EU to pull the global weight on the cancer issue.
Okay, but thank you. And I know Bettina and then Ivana.
So to go back to the topic of engaging, and my angle is of course mainly, particularly engaging patients. We're in cancer, so this is about cancer patients, and this is obviously my field of work. And sometimes what I think what is critical to get in this discussion back, and then we can extrapolate from engaging patients to engaging other stakeholders, because in the end this is like about an entire whole society all-in approach, is that the first question we should be asking ourselves is, why are we doing this? So, I mean, we shouldn't engage to engage. We should engage in order to achieve what? And the way, in my own community, the way we're currently thinking about it is that there is a way that we engage to raise awareness and in the interest of transparency and accessibility, because research is taxpayer funded. So I am a researcher, so I have a background as a physician and as a researcher, and I've always felt that we owe society access to what we have done with that money. This is our contribution to society, making our learnings accessible. And I find I used to work, I worked in a department together with paleontologists and molecular biologists, and my paleontologist colleagues were fantastic in making their work accessible. You can say, of course, a Tyrannosaurus rex is always more attractive than a cancer cell, but they were fantastic educators, and I think that's a part we should not forget. It's creating excitement for science. Yeah. If we want society to support science and innovation, there should be something in it, and I think we miss a trick in there because we're so stuck in our papers and all that. So that's one part. Another part is what I call user testing or user development. If you design a service for cancer patients, it should serve your local community. It should be designed for your local community. That's a certain type of interaction you need to organize. The same for products. If you develop a new digital device, like an app, you should test it with the people who are supposed to be using it afterwards. Then we have citizen science, which is yet another beast altogether, a very different process. I think there's a lot of room in health. We see a lot in environmental subjects, but not so much in health. And then we have something that is my particular hobby, well, not hobby, but my particular interest is research. And I'm interested in how can we get research more relevant to the issues that patients actually face, and how do we ensure faster translation of research findings into something that the patient derives benefit from. So I think we need a granularity, and we have to sharpen our concepts. And I stop there, but I think it requires a lot of work and thinking. And I really like the comment about the facilitation, that we have to spend thought on how we interact, because otherwise things go wrong very easily if one hasn't really structured how we talk to each other.
Ivana?
Yes, I think it's fantastic to listen to the two of you, and the excitement for science, but also how we could do that. We don't have to suffer of a complex of inferiority versus FDA, right? I also think we do have an opportunity to reposition cancer very high in the political agenda. Today, when I listened to Professor Mark Lawler, and he said, we have a cancer crisis going on. Yes, we know. We working on the field. And I'm really wondering, are politicians realizing it? Because politicians are people of action. They need to have a burning case to act upon. Like it was in COVID, where they did this and work. So in doing things differently, maybe it's also about the process. Maybe it's also about repositioning cancer high in the political agenda, because ultimately it's something which is affecting the patient, yes, we know, the family, the caregiver, the education of the children of the patient, the economy, taxpayer, and so on and so forth. It is a societal issue. And for the economists in the room, already today the dependency ratio in Europe is incredibly unbalanced. And that will create poverty, will create social crisis. So do we have to change our interlocutor, and instead of Ministry of Health and Research, maybe from Europe, you should talk to the Prime Minister and really raise it? That's a societal issue. It's not just a disease, unfortunately. So do we need a different level of leadership there? And not leadership as single leaders, because we do have leaders. People like you who were in the cancer mission, you have tons of leadership, but leadership as a process, systematic, not just a single individual.
So, Marius, what do you say?
Yeah.
You have a mic over there, you guys. You share.
Do you want to intervene, Christine? Right.
Yes, I was at a meeting recently on messenger RNA, and we were all different people around the room. And there was one person who finally said, do not take the issue of messenger RNA to answer all the questions on cancer. And so, of course, I had tons of things I wanted to say, equity, pediatric cancer, and it's funny I did not open my mouth because I really understood that he said something which was really important. Cancer, as you say, is complex. There's so much needs. There's so much we can do, and we saw that with the recommendations and all the people who came to us and said, you mustn't forget this and you mustn't forget that, right? But just, coming back here to ECHoS and why we're here, I do really think we need to focus on what the mission concept and the mission added value is. Otherwise, you cannot answer all the questions of stakeholders and citizens' engagement on cancer at the national, regional, and local level. Why not? But I think it would be complicated. And once again, the mission concept cannot answer, for me, all the questions related to cancer issues. Right? It cannot answer, it's not the way to do cancer research for all topics. Right? It's not the way for me to answer questions of, drug access or whatever. But we need, I think, to identify, and that's maybe, as I say, I always tell people what to do, maybe what ECHoS can do for the national hubs is to give guidelines or ideas of how to get people to identify what is the question, the need. Deepa had a very important way of saying it. I forgot, precise what the question is and try to really focus on that and see whether it is a mission action, whether it is a need that requires to have stakeholders and people together. And then once this is accepted, to actually go for it. But I don't think we can tackle everything with a mission concept action. But that's my point of view.
Yeah, I think that's a key point that I think one benefit of the Cancer Mission Hub for me is getting outside the echo chamber. I was a Marie Curie fellow under FP5. I've ran programs under FP6, FP7, H2020. I know the lingo, right? It's still confusing to me. I'm just thinking of the average, never mind, say, a person on the street, even the average researcher or clinician on the ground, it's kind of impenetrable, the European landscape, of how to get involved in it. So we're not really engaging in a wide level participation into our kind of most obvious partners.
How can we do that?
The Cancer Mission Hubs. So
Yeah.
that's the role of the Cancer Mission Hubs, is to get out there and talk to the community. There's obvious participants, and then there's less obvious participants, which is actually harder to do, because again, I gave the example of a homeless person. That's going to be difficult. You have more tangible, I suppose, more, for example, we've run a program for the last 2 years called Invisible Spectrum, because we're quite interested in seldom heard voices, or people who you don't often talk to. So, for example, we have a traveller community in Ireland. It's quite difficult to kind of get access to that in terms, and they have different health issues. We have, obviously, like other countries around Europe, we have different marginalised communities or minority groups. So, for example, we did a specific programme targeting and focusing on interaction with, not so much specifically in cancer research, more generally in precision kind of medicine area, with individuals from the Muslim communities in the Dublin area. And again, the first thing is a Roman Catholic, expired Roman Catholic who doesn't practice. I didn't really understand that there's different communities. You know what I mean? So you have to target different communities within the Muslim religion as well, and you have to be specific. And one of the things that we did is we interacted with community leaders to actually work on the kind of the appropriate approach. How do we do it effectively? and we have to tailor it for each of those communities.
Is it like building trust?
But also you need people who are actually in the community.
Yeah.
So, for example, I'm not part of that community, so we have to actually, I had a close kind of colleague of mine who was from that community, who was respected in the community, and he worked in terms of, and we had to work hard to actually kind of come up with a program that was beneficial for both parties. It wasn't just us coming in parachuting with our information, and you must understand that. It was actually co-developed with that community. So that's something, just an example. And I suppose the last, just to finish off, I think we need to be a bit more inventive about how we actually do things. So, for example, we're doing a lot of work now where we're doing work with artists, with filmmakers, to come up with different ways of targeting different communities. Because to a certain degree, a didactic PowerPoint presentation or way that we do things is kind of boring to people. And we need other ways of communicating.
Yeah, I fully agree that we should be really, really creative, really creative, in order to understand the individual needs and then to come with tailored intervention. I'll continue my idea after you, Mark. So go ahead.
Okay. I think one of the big opportunities for ECHoS is the political dimension at national level. Because I think if you can get ownership at national level in relation to political will, that will mean an awful lot, because that's where the problem is in relation to converting the excellent things that are done at European level, international level. So if you look, one of the best and the other thing is at national level, the politicians need to regard it as their own. If you look at one of the best initiatives that's political led was the 100,000 Genomes Project. Straightforward idea. A prime minister who actually had an invested interest in it because one of his kids had died of a rare genetic condition, and that's had a huge influence. So that would never have happened except for the actual will of the prime minister and to do that. So I think thinking about what are the opportunities at national level to get political buy-in is going to be critical, because that's how you transfer from the European perspective to that national perspective.
Yeah, I fully agree. And now we in Romania have like a law, not just a national cancer control plan, our first, but this is a law and was promulgated by our president. And the idea was that, without the European prioritization of the cancer at the political level, this probably should wait to be happening in our country probably many years. So I fully agree. And to your point, Ivana, I think it's very important to keep the topic on the political agenda. We know how to do it because we did it before. But at the societal level, and we should focus on this, I think we have a lot of challenges. And you, William, you mentioned that we should look to each of us, in fact, to each individual as a part of a social tissue, with their family, close friends, and we develop like a model on how to approach each individual at micro, meso, macro level. And for this, ECHoS, I think, is the best opportunity to build model in a different way, maybe in a visionary way, and to missions that models that are tailored to the pillars of the Beating Cancer Plan. The models are different when it comes to the prevention and screening, then the diagnosis and treatment. The stakeholders are different. The impact model are of course different. And just to introduce the next keyword in our discussion, the trust. I think we have a lot of experiences coming from the pandemic, and I think the experiences around the COVID-19 vaccination. We are in Portugal, the champion in Europe in terms of coverage with COVID-19 vaccines. But in the Central Eastern Europe, except Hungary, the percentage of people vaccinated is actually less than half compared to Portugal. And we try to understand this, and we publish a study, and there are some commonalities in different states like Romania, Bulgaria, and others. And my question is, how we would actually deal with this trust issue, and how much is the risk to have like a spillover effect coming from, this failure actually of the vaccination campaign in some member states when it comes to prevention of cancer, screening programs, HPV vaccination, because the numbers are also low in Central Eastern Europe. And the issue of trust, I think, is the key, and is not the trust you mentioned, Christine, messenger RNA. So we expect products for cancer based on this, but people ended the pandemic not having trust in messenger RNA. So this is something we should address. But it's also is the trust in the health sector, is the trust in politicians, around 20%, is the trust in media, around 20%. So, yeah.
I mean, one thing is to accept that there's a huge difference in trust in the different societies that are presented in EU. Right, so I come from Norway. We just discussed in the break from Norway and Sweden. We have societies with a high degree of trust, and that makes everything from introducing a smoking law or smoking ban law to have vaccination fairly easy. That won't be that. So we cannot have uniform approach in the different mission hubs in the different countries. I mean, just to accept the difference is one part.
I think what I'm often missed in the trust discussion is that it's like, oh, people don't trust us. Then I think the question should be, what have I done that people don't trust me? Because trust is earned. It's not something you can demand, just as you can't demand love. It is something that is granted. So I think it's like, how can we behave trustworthily so that people will trust us? I think that's the question we should be asking us. And I think if you reflect on the COVID pandemic and how the discussion started, it was like, oh, people are stupid not to believe that. It was quite controversial, and it was really like patronizing how people who are too stupid to get it were thinking about it. And we often actually talk about patients like that. They're just too stupid to understand that smoking is not good for them, or it's like it is that tone already. And I find it quite interesting that over the pandemic, when people realized that people were not getting vaccinated, the tone changed. There was way more emphasis on education, on accessible education. As you just said, we have to get out of our PowerPoints. And the tone changed, and the discourse got better after a beginning which was not so good. So I think we have to, our goal should be, we should be trustworthy. We should be worth people placing their trust in us.
Yeah, I think it's down to this again, this idea of power imbalance. Again, it's outside even science. If you have an interaction with someone and you don't, if it's not equal, there's going to be a problem around trust. So I think, we have this problem with what's called misinformation or misappropriation of information in the society. I think there's good and bad things about what's called empowerment. You know what I mean? I think it's very good that people actually are empowered to make their own decisions. But the problem is, the challenge can be, the control of that in some way. So when we're talking about implementing policy, you want to standardize things. But again, it's a natural conflict for individual decision making. So we are becoming a more individualized society. But then the counterbalance is how do we mainstream society? So we have an inherent conflict there that, for example, from a societal point of view, there's less community participation and support of individuals, and that will have knock-on impact when we talk about survivorship. That was really revealed and accentuated during the pandemic. How do people feel isolated, particularly if they're in remote communities.
Exactly.
And that culture of community support is not really there, it's less than it used to be because of the move towards individualization. So we have this conflict of, yes, great that we have people who can actually make decisions themselves, but because of that move towards a probably more selfish society, then it has knock-on impacts on broader impacts. So it's a tough one.
Yeah, I was thinking about Deepa's comments about framing good discussions with people around dilemmas and applying that to the mission and the plan and how that would work. And we have certain dilemmas, don't we, when it comes to eliminating HPV cancers. We have dilemmas around vaccination uptake or screening uptake, these sorts of things. And I wonder if the opportunity is presented by the plan and the mission to have those kind of discussions with the public. We've got to get over that trust barrier. So listening to people, Why is it that what are your concerns on the vaccination? What are your concerns on screening? And I think that might not otherwise occur unless we set those goals. So creating the goal means we have to get over the trust hurdle.
Well, thank you.
And maybe,
Yvonne.
if I may add, for me, and thank you, Richard, I 100% agree. Trust is also something that comes on the ground by really understanding each other, working together, and finding a solution together. I think when it comes to health for citizens, I think the time that somebody comes with a top-down solution to go and vaccinate, people will refuse it if they are not part of the journey. And unfortunately, there is also a lot of misinformation. Everybody has something to say, even if they have no knowledge, but fine.
Exactly.
We are living in democracy. But creating together, being together through, so close to each other, being together through the issue, and finding together a way to a solution, that slowly but surely, I think, will create trust.
Thank you. Ketil?
Yeah,
And we have a question. Should we let Ketil in and then the audience? Thank you.
Just to add on what you're saying, I think that we discuss here trusts between citizen and mission hub, but I think equal is trust within the different stakeholders and people. So do we trust a multinational company? Do we trust a mayor that cares for his city only? Do we trust a national prime minister that only cares about his country? So how do we align these interests? I think that's equally important.
Well, thank you. Please.
It became very interesting for me when you come into this question about trust. I live now in Lithuania and come from Sweden, and I see very, very differences in trust. And actually, we talk about research. Do you know there is a lot of research going on about trust? Yes. So maybe if you want on national level to implement something, you should study this research and see what is in this country and plan according to research, as you said, that you should do with the mission. Thank you.
Thank you. Thank you. Yes.
Good.
We should use the data. That's, yeah.
Yeah, thank you for your comment, and I think the models I mentioned and that are actually the opportunity in the ECHoS project should be actually developed in this multidisciplinary approach. None of us is social scientists, but we need actually to engage with them. They don't know, at least based on our experience, they don't know how actually to deal with the health systems. It's something new for them because they didn't being approached before the pandemic. So it's somehow it's a new field for them. So we should be able to, you know, as you said, Bettina, to make the topic attractive for them, and yes, to allocate resources, funding, and so on, and to be able to come with us in this process. Yeah.
So maybe we should try to wrap up this, I think, very interesting and fantastic discussion. And thank you also for participating from the audience. And if there is any more questions, so I feel free to ask this panel or contribute to our knowledge. So, yes?
I just want to follow up from the comment that was previously made. So I'd like to point to one particular researcher who has done a lot of work about how information is communicated, Leslie Fallowfield. So she's a kind of worldwide expert in the UK on how, for example, doctors communicate information to their patients. And again, body language, about the way that you transmit information has a big impact on the decision that that patient makes. And I think that's part of, you know, when we think about this kind of wider aspects of trust, it's how we actually do business, how we actually interact with others, the way that we bring people in. So I'll give you an example. When we established the All-Ireland Cancer Research Institute, one of the things that I was quite keen on is that we don't focus on who's the lead of the program, right? So we have a co-lead structure. We have 10 institutions co-lead. It can get a bit complicated. And you have certain people can push certain angles, but allows people the freedom to push forward if they want to. and to get what they want out of it, rather than focus on, oh, I'm the big boss, I'm the big lead of that program. And that was particularly important for me. This co-lead, distributed approach is the way forward, because it allows people to grow, and it doesn't stifle people.
Big difference to convince by you as a doctor to a patient than to get a country to decide, now will we do this for all our citizens.
Yes.
It's a total different option, a total different way to do. And you can think now, if we're going to do these missions, we in Lithuania have seven institutions who are engaged in this hub. I think it would be very exciting to see how should we organize. Is it on local level in some small rural city we should need change? Is it the ministry? Is it the politician? It is the parliament? We really have to think and not just talk about something. And actually, are you interested in this trust research? I think it is a group of Danish researchers who are the most interesting. And it's very interesting to read, but it's all over the world doing this. Thank you.
Yes, thank you. Yes, you go? Yes?
And then you.
Well, thank you, if I may. Listening to, I had to exit for a while, so I don't know if you have addressed this, but one of the things that I would like to ask and to have addressed here, and I would like to ask the comment from both Richard and then William, is about, in the case of Richard, you have at ECHO this parliamentary action against cancer. This is a transnational activity, let's say, with several parliamentarians at national level, at European level, and I think it's a powerful tool on policy making. And I was wondering if you can give us any clues, suggestions, advice on how to address or replicate or expand your experience also to our national contexts.
Yeah,
and then William, another thing, so
yeah,
go ahead.
I think it builds very much on the remarks that Mark brought up about connecting local and national politicians to everything that's going on. They are very passionate about cancer policy as well, and there should be a place found for them to be part of the implementation journey and to be raising questions in their national parliaments. And actually, the genesis of the idea comes from the European Cancer Pulse that was presented earlier. We have all of this valuable, very precise data about inequalities, but it can't sit by itself. Something needs to happen on the back of the data. So we felt we needed to create something that would link the data back into national parliaments. So that's been running for a few months now, and we're delighted by the participation that we are achieving. And I hope that it can link very closely with ECHoS in terms of your rollout of activities. We've got national elections in many countries this year where they'll be provided with information from the Cancer Pulse to guide their representations and their policy making. So it's an evolving area, and we're pretty keen to connect with anybody who's interested to link with that network.
This could be actually something that each one of us at ECHoS could then to expand the network on politicians that you have to get more. And I don't know if you want to comment. And Liam, I know that you also have a very nice work on charities and marginalized groups. It was briefly addressed here. I don't know if it was now because I said I was out for a second, but I really want to bring this up. And from what I know, it's a very interesting and not that common to involve charities and marginalized groups. Can you share your experience on how to address them and how to engage them, and what feedback have you received from these interactions?
Yeah, I think that covered the question around marginalised groups a bit when you probably stepped out, but I probably didn't cover the cancer charity part. So again, when we were setting up the All Ireland Cancer Research Institute, we were quite keen to interact with the cancer charity sector in Ireland, both in Northern Ireland and Republic of Ireland. The cancer charity sector is quite fragmented. You've got a lot of different charities. And we're quite keen to kind of, I suppose, come together and kind of provide a forum where we could interact, understand what each of the charities were interested in, and then come up with something that was of interest. Certainly the cancer charities some of them have very good interactions out into the community. Some of the bigger charities have a good track record of talking to other stakeholders, not just the usual suspects. I think the challenge is the smaller charities, and it's difficult for them because if they're small, how do they have the kind of resources to interact with the community? And I think that's where the benefit of a structure like ours, or a kind of cross-charity structure, allows that kind of interaction to occur. I think the challenge, I'm not sure what it's like in other European countries, but in our case, that participation and engagement with the community tends not to be funded. It's a difficult thing to be funded in a standard research grant. Maybe you can get some funding from under an EU program if you're involved in that EU program, but it's generally it's little side bits of money that you might have. It's not mainstreamed. So it's not there's an increasing emphasis on patient and public involvement and engagement, but it tends not to be mainstreamed. Now, one exception to, obviously, Mark Lawler's in the audience, there's some very good examples in the UK of, for example, a program that Mark is involved with, DataCan, where patients are involved as in a co-leadership way. It's not just like token involvement, it's actual upfront involvement from the start. But that needs to be supported. How do we look at successful models, and then how do we resource that properly? There's issues, for example, I'm paid to do research. Most people outside that community are not. They have their day jobs. Sometimes they're reimbursed for their activity. Often they're not. But what they do bring, and again, I don't like the term lay. If you look at the dictionary definition of lay, it's an individual that doesn't bring any specific expertise on a subject. But the average person on the street actually brings their expertise. They may be, for example, an accountant. They have experience in business. They come with not just their lived experience of a disease or a carer. They come with their own professional expertise that can be brought to bear. So we try to take advantage of that in our system, is understand what they can also contribute beyond their lived experience.
Thank you. And
yes, I just wanted to
continue. Could I just have a microphone for Anders?
Yes, I just wanted to continue on the charity aspect or involvement. For me, they're very important because the money they have for the research and the actions they do comes from citizens. So they have a very strong interaction with the outside world, not laymen. And they have also a way of trying to make sure that the way they're using the money, which comes from the people, answers the needs or an understanding of what the people are donating their money for. And so, yes, for me, when we did the French presidency meeting with the 5 missions to define the measures that were needed for citizen engagement, the working groups that I had before the meeting were essentially with charities trying to find the people who had interactions with the citizens. So yes, I think it is, quote, a stakeholder that I think we can really lean on and learn from.
Thank you.
Well, as a public health person, I have to bring in the issue of health literacy, because part of it relates to what Bettina was earlier referred to. You cannot blame someone because of their, let's say, limited capacity of understanding for whatever reason. And of course, we have 3 big circles of people when we discuss cancer. One is the ones who are survivors. They, of course, have very high acceptance of scientific evidence. They are convinced because they have been successfully treated. They are advocates, they are fighters, and so on. Then we have people who are at risk or just about to be diagnosed. they might have some skeptical notes around them, but they are still going to listen to a lot of what is being said. And then, of course, you know, there are the young, there are the ones who do not understand the time dimension. What does it mean that you are protecting your life 30 or 40 years down the road, when at 25 you probably think that you are immortal? And what kind of an investment it is to do. So Ketil was earlier referring to one size, it doesn't work as one size fits all, not across countries, but even within the country. Exactly. And I have a practical example. We have the colorectal cancer screening program run by our institute. And this year, or was it last year, they decided for a very provocative slogan, which appeals more to the people who are more expressive, let me say, in their language. And some people were shocked. How can you allow yourself that you are addressing the public with such language? But it did appeal to the populations that we wanted to appeal to. So you cannot always use a high academic language just because you feel that you have to remain on top of things and that you have to be decent. And I think that acceptance is very important. My last example, I was at a Europa Colon event years ago in Poland, and Poland decided to do a colonoscopy-based screening program. And it didn't, I hope it's working better now, I don't know, but at that point there were problems because colonoscopy was not acceptable as a first-line method, because people know it's not like walking through the door and exposing yourself to 5 minutes of quick examination. And probably nobody in advance tested whether, why is it important from the medical point of view does not necessarily fit the acceptability in the population, especially among people who are seemingly healthy and not patients. Thank you.
Thank you. Thank you. So, yeah, this will be the last from the audience, but anyway, there.
Hello, thank you so much for the inspirational discussion. I just have as a comment and as a question, because I myself am an early career researcher. And what I believe is that it's very important as well in the citizen engagement part that also researchers are engaged back. And that perhaps investing a little bit or focus in exactly making sure that researchers understand their role as well in this part. And particularly because researchers, unlike clinicians, are not trained at all in how to communicate with patients or people in general. What are the initiatives that you have in your countries or that are planned maybe in this mission for really training researchers in this scientific communication approach? And particularly in mind that because there's different groups, you have policymakers, you have different patients, you have people that are maybe disengaged because they're not patients, and probably researchers will have different motivations to address each of them. And so that this would be maybe a spectrum that would be interesting to explore, even at a nationwide level in each country, that researchers would feel more engaged in this type of discussion. So I would love to hear your thoughts.
Thank you. I think that we will have just one answer to this question, and then I just can encourage everyone to continue the conversation after this panel. But please, Bettina.
So I separate communication from involvement in research projects. So communication, Emma Doris in Dublin has done a fantastic job in partnering a researcher with a layperson to write an accessible abstract. She has even a protocol. I don't think I keep pestering her to publish it finally, but I have the protocol in my inbox if you want. So it is basically a process like how you write different, they have to be mutually reviewed. In the end, you have a product that is basically both scientifically valid as well as accessible. And both sides have learned. That's what I really like about that one. If you want to involve patients in a research project, let's say you want to apply for an EU grant, and we hope lots of EU grants come out of all of this, there you need a proper strategy, and that takes some kind of thinking about whom you engage and how you engage them. So from my perspective, so I also have a research background and I'm a patient advocate, I'm interested in the research design and questions like model systems, and there you have to be careful in whom you choose and how you interact. There are some interesting initiatives out there. The German Ministry for Education and Research is doing some interesting work, for example, in that. They train their researchers how they want them to involve civil society and patients into their projects. So there is quite a bit of going on. But as someone said this earlier, it's quite dispersed and it's not easy to access. But there are resources. So you can contact me. I can give you something afterwards.
Thank you. Yeah, that was good. And thank you so much. I would just say that I appreciate your contribution to this panel, but also to ECHoS, because as work package lead, I think we have a lot of inspiration, very, I would say, advice, and also good collaboration with all of you sitting here and listening. And I will just say that I think, Marius, the way forward is together.
Yeah. This is the keyword.
Yeah.
Yeah. Thank you all.
Thank you.
Excellent.
Thank you.
So interactive. It's perfect. Yeah.
Send Annabella the list of the ambassadors already.
Thank you. Thank you very much for this very pleasant roundtable. Just moving forward to closing remarks, I call the stage now Professor Catarina Rezende de Oliveira. Thank you.
So, dear all, we are getting close to the end of the day. And so in the last session of this meeting, it is my pleasure to introduce the next two speakers. To open the session, and on behalf of the Swedish Presidency of the Council of the European Union, Dr. Helena Brandström, Deputy National Cancer Coordinator for the Swedish Association of Local Authorities and Regions, will guide us in the strategic vision for cancer research. As you know, the Swedish presidency of the Council started in January and will finish at the end of next month. Spain will then assume the presidency. So following the participation of Dr. Helena, we will have the pleasure of listening to Dr. Rosario Perona, Deputy Director of the Instituto de Saúde Carlos III in Madrid, who will speak about the interest of the Spanish Ministry of Science in cancer research, oriented towards personalized medicine, and how Spain is financing these projects aligned with the goals of the cancer mission. So, without further ado, Helena, please, the floor is yours.
Thank you, and dear all. I'm very delighted to take part in this kick-off meeting of establishing cancer mission hubs in the EU. And I want to start to thank the organizers for today's meeting for a very well-organized, interesting, and inspiring meeting. My name is Helena Brännström, and I'm Deputy National Cancer Coordinator in Sweden, and I work for the Swedish Association of Local Authorities and Regions and Confederation of Regional Cancer Centers. And in Sweden, a country with 10 million people, we have a healthcare system that is organized by our 21 regions, and the cancer care run by the regions are free for all. Healthcare in Sweden is a public responsibility and is largely tax-financed. We have had a national cancer strategy since 2009, and when the cancer strategy was launched, Sweden established 6 regional cancer centers to support the healthcare regions and increase the quality in cancer care and improving outcomes, as well as maximizing the efficiency of the use of the healthcare resources throughout the patient pathways. The regional cancer centers has a supportive, stimulating and coordinating role developing cancer care according to the intention of the Swedish National Cancer Strategy, and of course now also according to the Europe Beating Cancer Plan. Back in 2009, we kick-started the development of a patient-focused, accessible and equitable cancer care, and national care programs, diagnose-specific cancer registers, standardized care process, patients and next-of-kin councils and contact nurses are some examples. And in recent years, Sweden has also established this far 3 cancer comprehensive centers in the university hospitals, which strengthen the excellent conditions for research, providing patients with the best possible care. And this structure for local, regional and national collaboration, both with patients and professionals, provided by the RCCs together with the CCCs, can serve as a model for other countries how to build an infrastructure for cancer care. However, even though many good achievements in the latest years in cancer care, we are still tackling the same problem that the rest of the EU countries. And as a start of the EU presidency, we organized a conference on cancer in February under the title Equity, Excellence and Innovation, Modern Cancer Care for All, Europe Beating Cancer Plan, Eradicating Inequalities Within Cancer Care. And in addition to presenting the latest deliverables on the EU Cancer Plan, the participants in the conference discussed the topics that Sweden, together with all European countries, need to tackle to reach the goal of the European Beating Cancer Plan, namely prevention, early detections, and the condition for data-driven cancer care. And for example, a challenge in the field of prevention is that lifestyle habits and lifespan vary between different groups and socioeconomic areas in Sweden, Swedish societies, just like in most other EU countries. And health disparities are widening quickly, and the healthcare systems struggle to reach the communities using traditional methods. And therefore, we need to think in new ways. A Swedish example that we presented at the EU conference in February is how to work with peer-to-peer advisors. Peer-to-peer advisors are engaged individuals helping to reduce those health divides by spreading information on cancer prevention and healthy lifestyle habits in their communities through public spaces, schools, and clubs. They are trained by the regional cancer centers on the European Code Against Cancer to inform and advise their communities on diet, tobacco, alcohol, physical activity, sun exposure, and the importance of participating in screening and vaccination program. And this is just one example how we can reach beyond the traditional healthcare. And if all of us participating today work together, we can spread new innovative examples from different countries all over Europe and help each other to tackle the cancer burden. Another example of our common European challenge is the demographic trend of an aging population, together with a significant shortage of healthcare professionals. And the demand of healthcare services and long-term care increases, and this places a strain on the healthcare system, on workforce. And to address this issue, we need to explore new innovative solutions, such as the use of technology to provide remote care, which can help to alleviate the burden of healthcare professionals and improve access to cancer care for all cancer patients. But addressing these challenges will require coordinated efforts from policymakers, healthcare providers, stakeholders, to ensure that the healthcare system are equipped to meet the needs of the future cancer care. And we need to reach beyond the traditional way of working and start to involve governmental, healthcare, academic, and non-profit organizations to work together. And in summary, the complexity of cancer requires a multidisciplinary and international approach, and the European Cancer Plan and the Cancer Mission Hubs can facilitate cooperation among researchers, clinicians, patients, and industry to share data, expertise, and resources. And together we can make a significant progress toward reducing the burden and improving cancer outcomes for patients across Europe. And I feel very confident that Spain, when taking over the presidency, will continue to work for a better and more equal cancer care in Europe. Thank you.
So thank you very much, Dr. Elena. We will have now Dr. Rosario Perona.
So good afternoon. Thank you so much for the invitation to almost close this interesting eco-landing in this new initiative, a very exciting initiative. And thank you for the good wishes for the Sweden change to the Spanish presidency in the other European Union. So I hope to have such good success like the Swedish presidency. We in Spain, because I'm in an institute and most of the biomedical research is in charge in our institute, which is the Institute Salud Carlos III, depending on the Ministry of Science, which is the most that funding schemes in every kind of science. So the strategy of our institution the last 3 years has been focusing in cancer financing schemes that strengthen, on the one hand, the public health institutions, the research group, and also the industry by financing projects, hospital infrastructures, and industry, mainly by loans. The central axis of the research strategy is the personalized medicine focused on cancer research. For that, the Spanish government has implemented two main tools. In one part is a strategic project for economy recovery and transformation using EU funds focused on health and cancer research, which is the Cutting Edge Health, which is investing 1,000 million euros in these projects, and also to create research structures such as the IMPACT program, which is a precision medicine infrastructure associated with science and technology, configured with three legs: the IMPACT strategy, 3 axes: the predictive medicine, data science, and genomics medicine. So our institution has financed using these personalized medicine projects that has the main object to implement the results from research to the clinical practice in the clinics, and to renew the protocols that the hospital can have, So these are implementation program projects that have feed the impact infrastructure, and we hope that this investment of more than 150 million euros will have a good results in the health of the cancer patients. And besides that, we have been collaborating with the Institutes of Technical Development, CETETI, that belongs also to the Ministry of Science, implementing research products that coordinate groups from laboratory of hospitals with companies that can transfer these results to the industry and the clinical practice and industry development in the main to speed up the process to get all these findings to the patients, which is that at the final they deserves these results. So along with this strategy, in the last year, we have a call that is still not solved. That is the creation of a consortium of advanced therapies at the state level, which will contribute to bring to the clinic those results in advanced therapies based on gene, cell, or tissue therapy. And of course, cancer is one of the pathologies that can benefit most of this initiative. So having in mind also always the personalized medicine in mind, we have implemented different strategies that are giving good results, and I hope we continue on working on this way, and putting all our effort, economical effort, trying to bring to the public those strategies that can have the prevention, the treatment, and the early diagnosis in cancer. Always using personalized medicine strategies. I really want to congratulate. Our institution is an associate of ECHoS, of this initiative, and I want to really congratulate for assembling this fantastic group of initiative and researchers, and especially like having these two roundtables, very interesting roundtables that we have this morning. And I hope this landing with progress and with initiative that which the EU patients deserve and they need. So thank you so much for the invitation, and we wish you very much success and for the benefit of patients, as I said. Thank you so much.
Thank you, Rosario. Thank you, Elena. Missing Elena, sorry. There. For these nice words. And now, just to close the meeting, I have to say, wow. I'm really, really enthusiastic about the day today and about ECHoS and all the discussions that we had here. To start, we started the day with learning about the commitment of the European institutions, meaning the Parliament and the Commission, on beating cancer. Then we had this helicopter view. We don't have time for everything, but this helicopter view on the state of the cancer in Europe by Mark Lawler, which highlighted some inequalities that we need to tackle. And we also learned how both DG RTD, so research, and DG Santé are aligned so that together we can fight it by investing in mission. And I must say, it's not just the commitment, it's not putting money forward and waiting things for happening. We see that 2 years after starting the missions, we are now going through an evaluation process. We are really, or there was this clear indication that the commitment is really to make things change, to make things happen, not just say, money was there, you didn't do it because you didn't want. So we saw it, and we also see that with the screening programs. The screening programs are being ambitious and are being aligned. And that is also then on the scope of this project. It's not just about the potential in ECHoS, the potential we have to do things. It's not just about doing things, it's also about taking part of the opportunities that are out there. But because the opportunities are there, sometimes we need a network, sometimes we need the communications, sometimes we need other knowledge that we can share between each one of us. And I think this is actually the power of the community that we see here. And on top of this, we had the opportunity to learn more about the member states. We had the political commitment, and not just political, financial and so on, by the European institutions. But we learned in this morning about the Portuguese government also addressing and not sponsoring, but yeah, the fight against cancer. And now we had this view from the Swedish representative of the Ministry of Technology, which is actually now taking care of the presidency of the European Council. And we learn now from Rosario about the investment and the commitment that Spain has in cancer, though not really open, because probably couldn't, on what will be the next actions. We can reflect here on the political agenda on cancer in Spain and hope that the cancer will be in the agenda for the next presidency of the Council. So, with no further ado, I like to to acknowledge the presence of you all here today till the end. And I'm closing the meeting now, but without saying first that we are having the debate now in Portuguese. I welcome you to join, and thank you all, and the bus will be waiting for you for dinner at 7. Thank you.